I'm like, oh my God. I always like you were running the code.
I can see the presentation, Dr. Luca.
Awesome. Can you hear me?
Yeah, I can hear you too.
Oh, good. Okay.
Yeah.
All right. Do you know if anyone else is joining online?
I'm not sure. There might be one or two more people, but I know we have people up north, so I don't know if they're joining. The internet's not great enough for them to join.
That's what we're gonna do. We're gonna be like,
Probably going to get started after 30. We have one person online so far. Just verifying. I don't know where the mic is exactly, but you could definitely hear me. Yeah.
Yeah, I can still hear you.
All right. So I'll just go ahead and get started. Let me just make sure that this actually advances my slides. So. Yeah, that makes a lot of sense. It is a little awkward, not gonna lie. Okay. Yeah, no, but it's not, at least I could turn it towards me, which is nice. Let me just make sure I figure out how to advance the slides. Oh yeah, that worked. Yeah. Okay. Perfect. So I want to find this. Oh, it's a little awkward. Okay. So hi everyone. I'm Nadia. I don't know if everyone would have interacted with me. I'm one of the rheumatologists. I've been at GEO for almost about 3 years now. And I was asked very specifically to give a talk on CRMO or CNO. So that's the focus of the session today. And if there's time afterwards, if you guys have any other burning rheumatology questions, happy to try and answer those. So this is pretty just kind of basic overview of the condition. And I really tried to think about, what's most useful from a general pediatrics perspective, and how to identify this condition, because it can be fairly tricky. So our objectives today are to describe the clinical presentation of this condition. Now, I'm going to use the term CNO because that's the most kind of comprehensive umbrella term, but in the literature and even in clinical conversation, you might hear the RMO, which is chronic recurrent multifocal osteomyelitis, but that has been changed to the more umbrella term of CNO because it's not always multifocal and it's not always recurrent. So it's a bit of a misnomer. And then it's actually good timing for this talk because literally just in the last year, they finally published classification criteria for CNO. So up to now, there were some kind of diagnostic criteria, but nothing that was sort of validated, made the diagnosis harder. So now we do have something to go on. And then at the end, we'll review the kind of general diagnostic and management approach as we're working these patients up. Any questions before I get started? Perfect. All right, so we're going to start with a case. I find that that's always helpful. And this is a real patient of mine that I met a couple of years ago. So he presented as a 9-year-old to me, previously perfectly healthy boy. And he was referred with a 7-month history of pain to his left hip, which then moved into his right hip, and then seemed to migrate into the knees and ankles. So everything was in the lower extremities. And he was a very competitive hockey player. And the biggest thing that the family was concerned about was that he was unable to play hockey. And even to the point where like he's having trouble at recess, kind of getting around with friends and playing with friends. So they had tried some Advil, which did help the pain, but as soon as it, kind of wore off, the pain would return. And his full review systems, rheumatologic review systems, was completely negative, and he's been systemically quite well. So on his exam, I just put the focused MSK exam up there, but his general exam was really unremarkable. He had a normal modified Schober. On focused exam, he did have pain around the right greater trochanter, and not specific. The Faber test, which we do to determine if there's sacroiliac pain, only resulted in pain to the right lateral thigh region. He did seem to have a bit of an abnormal gait to me. Kind of described it as a bit of a waddling gait and a little bit out-toey. And his peripheral joints were absolutely perfect. I couldn't detect any swelling or reduced range of motion. He'd had a workup before coming to me. He had actually seen orthopedics first, so that's who referred him. And generally, his general labs were all completely normal. ESR and PRP were normal. His TTG was negative. TSH was probably not significant, but mildly low. They did Lyme serology, ANAs, and HLA-B27. So everything was really kind of unremarkable. Where to go from here? He did come with some imaging, so I won't make you guys guess what's on the imaging. But basically, he had x-rays which were normal. He had ultrasound, which didn't show any hip effusions or any abnormalities in that area. But he did have some changes on here. So his first hip MRI actually showed some bone marrow edema and enhancement around the left ischiopubic chondrosis, which of course is Van Neck-Oldenburg disease. And I was like, I have no idea what this is. I just kind of looked it up, and it's one of these, weird orthopedic diagnoses. And then, but they also saw this kind of milder degree of bone marrow edema in the bilateral body of the ilium, anterior aspect of the acetabulum. But they said that could be stress related. He's a hockey player, so it's, kind of hard. All of it's kind of hard to put together. So they kind of managed him conservatively in ortho. And then they ended up repeating his imaging about 4 months later, as we do. So, so that MRI also showed some other findings. So labral tears bilaterally. And they also queried mild cam deformity bilaterally. So all of these are kind of more mechanical reasons to have hip pain. But they once again did see the edema in the acetabula. Increased on the right and decreased on the left, and then some improvement in the edema in the anterior pubic ramus of the left side, and that ischiopubic chondrosis region. And then they said incidental finding of bone marrow edema in the third and fourth sacral segments. So again, a very kind of hard to interpret MRI, which is kind of par for the course in these patients. But the radiologist did put their lovely phrase of findings may be concerning for CRMO for clinical correlation. So that's what prompted his reference. Okay, so that's kind of setting up the stage for kind of the presentation of these types of patients. So what is CNO? What is CRMO? Basically, it's chronic bone inflammation with no apparent cause. So it can't be explained through infection or other conditions. And it is characterized by specific types of lesions. Usually they are a mixture of lytic, sclerotic, and hyperostotic lesions. which again is very non-specific. It's not, none of this is like diagnostic, but that's what we see. Why do we care? So why do we want to identify these patients? Well, I mean, first of all, we want to make sure that we're not dealing with some other thing that could be a lot more serious than CRMO. However, CRMO or CNO itself can lead to issues because we are dealing with a growing skeleton. So we can see deformities due to bony expansion. That's most impressive, you know, if you're dealing with bones in the face, collarbones, things like that. That's very obvious. In the vertebrae and even in the long bones, those lesions can cause fragility and lead to pathologic fractures. So that's obviously something we'd like to avoid. And then if the lesions do involve the growth plate, you can get dysreflexia in your limbs. So these are all the reasons why we want to identify and treat these patients. Of course, also pain. No one can't undervalue the fact of living in chronic pain can lead to a host of other problems as well. Okay, so it is a rare condition. Its estimated incidence is around 0.4 to 2.3 in 100,000 children. They think this is likely an underestimation due to the difficulty of diagnosing this condition and the delay in diagnosis. The peak age of onset really is in those kind of school age years between 9 and 11, and it is slightly more common in females. And this condition most commonly affects Caucasians, but can affect all of them. Definitely seen that. Just stop me if you guys have any questions, because it's pretty informal. Yeah. Okay. So as I mentioned, we do now have like hot off the press classification criteria that were published with input through EULAR and the ACR, which are the kind of two big bodies in rheumatology. So they have 3 steps to their diagnostic process. And I should say every time we talk about classification criteria, they're really they're not necessarily meant for diagnosis. We always say they're meant to categorize patients, especially for research. So making sure that they're kind of a more homogeneous group of patients for research purposes, but we do definitely apply them in the clinical sphere as well. And I do think that this particular set of criteria is pretty helpful. So in the first step, you need to verify entry criteria. So as I mentioned, this is a chronic condition. So, you know, bone pain for 1 week is not going to cut it. Typically, this is something that is going on for longer. Age of onset, less than 18. And the reason for that, we do believe this is a primarily pediatric condition. There is an adult correlate that you guys might have heard of called SAPO, which is, yeah, not for you to know, don't worry. But it's in the same spectrum as CRMO. People think, and some people feel like all of this is on the same spectrum. But anyways, for our purposes, we're dealing with pediatrics. And then you do need to have abnormal imaging. So either on an X-ray or MRI, CT, bone scan in areas that are not clearly at risk. So those are your entry criteria. Pretty general, broad strokes. But if you had bone pain and normal imaging, you would not. Example. Okay. So as I mentioned, it is a bit of a non-specific presentation, and I think it's worth mentioning that often early on, it could actually be completely asymptomatic, or you could have a patient with pain in one location, but even though they've got lesions somewhere else, they're asymptomatic in those other locations. So that can be fairly tricky. And it's usually kind of insidious onset. It's not like a sudden 1 day, no pain, the next day, severe pain type of presentation. And then what I want to point out, because I think this is really important, because in arthritis, we always like try to drive home that the pain is and stiffness is worse in the morning, and then it gets better throughout the day with activity. This is the opposite pattern. So they tend to be fine at rest, fine in the morning, but then a lot worse in the evening or even overnight, and a lot worse with activity. So that's another just like really important contrast. There may be something to see. I would say in my clinical experience, which is very rare, that I've seen any swelling, warmth, or tenderness. A tenderness, yes. Tenderness for sure, we can see, but the warmth and swelling, very rare. They may have some low-grade fevers, but typically not like super febrile. And we definitely do see elevation of the inflammatory markers, but it's not mandatory by any means. And they're quoting about 50%. And it's not high-grade elevations either. Oh, that's okay.
Do you find that you get referrals from oncology? I feel like if I had, you know, a patient like that would
Yeah, so
kind of my first thought about where to send them.
100%. So oncology will not. Yeah, it's rarely oncology to us. It's usually I find. Yeah, I find that I think the ones that tend to get directly referred to oncology are obvious cancer. Do you know what I mean? So if there's diagnostic uncertainty, they tend to come to us first, especially if they're not super sick systemically sick. Yeah. But it is scary. Like this is our biggest fear, is missing cancer. So that's why we're always so like anxious to get these referrals and just be like, can I see you know?
Oncology, then we would start using a BMA to look at the bone marrow and see if it's for CRM, or does that doesn't work out that way?
Sorry.
Like if say we have a patient and they get sent to oncology,
Yeah.
investigate for it.
Yeah.
Yes, the cell lines don't work, but yeah, from a clinical curiosity perspective,
Yeah.
I do a BMA. If I find anything on the aspirate that would lead me towards CRMO.
Yeah, so we're going to
Nadia.
come a little bit to that because there's the bone marrow aspirate versus bone biopsy. The bone marrow aspirate in CRMO or CNO patients is likely to be completely normal, as opposed to leukemia patients. So, but the bone biopsy is also helpful. Yeah. What happened there? Whoops, hold on. Did something funny happened. Okay. So the other thing we look for very, very specifically is the affected areas. That can help us try to just tease it out. So what we're looking at in the most common cases is we're looking at epiphyseal and metaphyseal lesions. We're not looking at the diaphysis. We're really focused on that specific region of the long bones. And the most common bone to be affected is the femur, followed by tibia and humerus. And then the other big hit area is the vertebral bones. That's affected in up to a third of patients. And that's our most concerning area because it can result in concussion fractures. Other common areas are the pelvis, the sacrum, and the hip bones, like the acetabula, chest bones, so even ribs could be affected. And then if you get a clavicle or a mandible, you're really cooking because that's like really specific for unifocal disease. Like we're excited to see that because then that makes us more confident about the condition. But at the end of the day, the take-home message here is that the diagnosis relies heavily on radiology. It's a really impossible diagnosis to make clinically. So we'll go over the radiographic findings. So plain radiographs can be helpful, although early on they can come in normal. That's limiting. But you may see, if you're lucky, you'll see these kind of classic lytic, sclerotic, or mixed lesions at the distal metastases, as you can see with those arrows. You may see hyperostosis, which is seen here in the clavicle, like very widened, clavicle. And then they also describe periosteal reaction. So periosteal reaction, there's different types. We're looking for kind of the more smooth, non-aggressive type of periosteal reaction. Other types can be seen with cancers and whatnot. CT scans, I would say we don't do often. They tend to not add much to the X-ray, and of course the radiation is a concern. So I would say not something you need to do, but you can do just to confirm what you're seeing on an X-ray. The money really is in the MRI. So that is currently the reference standard for imaging diagnosis. And what we're looking for is bone marrow edema. That's hyperintense on T2 Lister imaging. And if there's hyperostosis and osteitis, that tends to be hypointense on T1 and T2. And then you'll notice we often will request a whole body MRI. And there is a protocol here at CHIO that they do specifically for this query of CNO, where it's not like, it's certainly not going to be every view of every area. It is an abbreviated scan, but it gives us a good idea of whether there's many lesions and anything that's kind of subclinical. And the real reason to do it is it might alter your treatment. If there is, though, like you pick something up on a whole body, you're really curious about that, often radiology will recommend go and do a dedicated image of that region as well. A lot of imaging.
Is there
Yeah, so there is. I'm going to just talk about that in the next slide after this. Yeah, so I just wanted to show an example, though, of the full body MRI stir. So what we're looking for here. So in this particular image, we're seeing signal here in the proximal humeri, and then classic kind of distal femur, proximal tibial metaphyseal. Okay. Sorry. I think the foot is okay. Yeah, I think it's just vessel, or yeah, I don't think that that's anything concerning because it's not in the bone. I don't know if they have arthritis in there, but and then this is a more kind of focused. Can you guys see that well? Am I covering this? Sorry. Focused version of looking at the sacrum and pelvis, and this is kind of like a more acetabular lesion there, kind of like. Okay, so the other two imaging modalities, so bone scans were used historically. Even when I was a fellow, we did use them occasionally, but if we couldn't get the whole body MRI, as like your whole body survey, but they're definitely not as good as MRI. They're not as sensitive and not as specific. It's hard because of like the growth plates and signal coming from that. So it's fallen out of favor. And then the PET scan. So the PET scan is highly sensitive and specific. And apparently, I don't have that much. I wouldn't say I've ever used a PET scan in this condition up to now, but apparently it can differentiate between chronic change and acute, like kind of active lesions. And there's something called an SEV that can quantify the disease severity over time, which is kind of cool. But they kind of report that the utility remains limited due to higher radiation exposure. But it's definitely something that could be quite useful. Okay, so now we're on step 2. So we need to verify exclusion criteria. So you'll hear us say that CNO is a diagnosis of exclusion, which means we have to really do our due diligence to make sure we're not missing something else. And so if there's any evidence of a mutually exclusive mimicker disease, then you can't give a diagnosis of CNO. There's a lot of mimicker diseases that I'll show you. And then they actually put platelets less than 100. I think that must be based on, I didn't delve too much into this, but it must be based on like case studies or a series where that might have been a predictor for malignancy or infection or something like that. LDH concerning for malignancy. And then if they have a complete and sustained clinical and laboratory response to antimicrobial treatment alone.
Does that mean you have to do a trial against that?
Does not. But if they have, like, if they come to you with that history, then it excludes. Yeah, correct. Okay, so the list of differential diagnoses is extensive, and I won't go into all of it, but the big categories in our minds are always infection and malignancy. Those are number 1, 2, 3, 4, 5. So, so this is kind of all the things that we're just need to make sure is not going on. And then an interesting differential that's come up recently is scurvy. I don't know if you guys have seen any of the cases that have come up. Yeah. So, so I would say if you have like a developmentally delayed patient or a autistic patient who has a very restricted diet, that should actually be your first thought. And on imaging, it can look exactly like serum. So it's pretty crazy. Yeah. So that's what I would say in that situation is run your vitamin C level and start vitamin C. And if that solves all your problems, then they don't need to see it. Yeah. It might not look classic like this, but they do tend to have like these abnormal bone signals because of some inflammation. Any questions about the differential diagnosis? I'm going to go into like the diagnostic approach where we rule things out in a minute, but I just want you to be aware of what the vast difference. Okay. Oh, sorry. I did have a little slide on vitamin C. So what they think is happening is that there's actually a periosteal or soft tissue hemorrhage that's occurring due to the vitamin C deficiency because of the capillary fragility. And their presentation, when you look at these cases, they tend to have generalized lower extremity pain, not wanting to walk, not able to weight bear in an intelligent gait. And apparently in infants, there's a characteristic frog leg position. Older children may present with knee contractures. They may actually get swelling of their joints as well. And they may get spontaneous fractures. So very kind of similar presentation overall. Okay, so then step 3 is to, I didn't go into all the scoring because you don't need to know this, but I just wanted you to be aware of what is scored in this final step. So they give a number value to all these various levels, and then if you meet the threshold, then it's likely that you can classify as CNO. But the things that we're looking for are findings on bone biopsy, which I'm going to go into, age greater than 3, the sites of the bone lesions. So if you have clavicle and or mandible, you get a lot of points. But if you have skull or hand, it's less points. Yeah, or I don't think they subtract, but I think it's like 0 because it's very unlikely to be CNO. Yeah, and then distribution of lesions on imaging. So I take a little bit, like, yes, in an ideal textbook world, it's multifocal symmetrical, but in the real world, I don't find that it is often that. But if it is, it's helpful. And then there's these associated conditions that we tend to see. So higher index of suspicion in patients with IBD. I'll show you the cutaneous manifestations, and then there's an overlap with axial arthritis. So patients who have spondyloarthropathy can also have CNO. And then as far as other things, so fever should be, if it's present, it should be low grade, but if it's absent, it's even more helpful because it kind of speaks against the other conditions. And then levels of hemoglobin, ESR, and CRP are listed there. So those cutoffs are really meant to kind of try to exclude infection and malignancy. Okay, so pathology. So as you saw on the previous slide, it said inflammation and fibrosis is helpful. So I will just say that the pathology in CNO is not necessarily meant to be diagnostic. The primary reason to do the biopsy is to rule out, not to rule in. So that's typically when you'll see us order that. But what you would see in a patient with CNO is if it's early on, you'll get this inflammatory infiltrate made up of neutrophils and mast cells. And then later it turns into a more chronic and mix of cells, macrophages, lymphocytes, and plasma cells. And then you may start to see, depending on where they are in their disease spectrum, more like fibrosis and sclerosis. If you have a mix of inflammation and fibrosis, they say that that's more indicative of CNO because it just shows that chronicity. Okay, so the cutaneous manifestations, we always screen for. So we have a higher index of suspicion in patients who have psoriasis or palmoplantar pustulosis, pyoderma gangrenosum, acne fulminans, so not just regular old acne, like cystic acne, and then hidradenitis suppurativa. So what all of these conditions have in common, they tend to be very like neutrophilic dermatoses, right? So it speaks to that like in sort of innate arm of the immune system being overactive, and kind of, yeah, just fits with the whole what we understand about the pathophysiology of CNO. Okay, so the diagnostic approach, I think this is probably the most useful part here, is kind of what to do when you're presented with a patient like this. So entry criteria, you know, you've got bone pain or MSK pain for more than 6 weeks. On your history and physical, you're looking at screening for any of the associated conditions that I just mentioned, but you're also looking for red flags for other things. So that's the main part of your history, is really teasing out whether there's any red flags. And then in your blood work, your basic workup for these patients includes the first bullet there, which is our basic blood work, including some bone labs, of course. And then the other tests that are listed are more for ruling out other things. And you may not need to do all of them depending on your history and physical, but this is kind of like the list that's recommended in the paper to consider.
So what makes you do genetic?
Oh yeah, I didn't spend too much time on that. There are weird and wonderful genetic conditions that can present with bone pain. They're mostly in our realm in rheumatology with like autoinflammatory conditions that if we pick something up on the history and physical, we might want to do genetic testing rather than call them CNO. Yeah, it's on the slide with the differential diagnosis if you want to look back at that. Okay, so once you've done that, of course, you're going to do imaging. So you're going to do x-rays in the chance that you do find something helpful, but you also want to like rule out obvious stuff like or other bony abnormalities. And then typically we would start with a regional MRI if it's like a very specific location that tends to be problematic, to get a feel for what's there, and also rule out the other differentials, infection and malignancy. And then if we find something in the regional MRI that's sort of suggestive, could be consistent with CNO, then we would always do the whole body MRI sequence to give us the full understanding of the presentation, help us with our treatment. Make sense? Okay. Okay, so then you need to decide at this stage, are you satisfied with your history, physical, labs, and now your pattern of bone involvement? Are you kind of satisfied with, you've ruled everything else out and you can go ahead and call it CNO and treat as such? Or is there enough diagnostic uncertainty or atypical lesions that you need to do more workup? And that's often where we it can be very challenging, I would say. So what they say is typical is the multifocal symmetrical lesions, involvement of the metaphyses and epiphyses, the clavicle, mandible, long bones, and vertebral bodies. And then if you have unifocal, if you have clavicle or mandible, then you could be pretty happy about that. However, if it's unifocal and it's not clavicle or mandible, that's going to be a little bit more concerning, more difficult. Any diaphyseal involvement, not typical. Cranial bone, And then specific findings like Brody's abscess or osseous fistulas would not be typical in CNO. And then the diffuse distribution pattern of bone, I didn't quite understand, but I think it's referring to like patients with bony mets, like they just kind of have little signals everywhere. They're not like more focal. So, okay, so if that's the case, if you are in that second box, then that's where the bone biopsy is. And so for the bone biopsy, of course, we're looking at the histology, but we're also looking at cultures and PCRs to make sure we're especially not missing like those kind of more insidious mycobacterial infections that could cause osteomyelitis, and then consider bone marrow biopsy if you have any concern about hematologic. Any questions about that? All right, so now treatment. Treatment is not too bad. So interestingly, it's one of these conditions that actually responds to NSAIDs, which always surprises me. I'm always like, how is this working? But it does. So up to 97% of patients are going to respond to NSAIDs. And typically naproxen is what we'll use. They do report a clinical remission of 51%, so not great at 12 months. And I do see this clinically that there is a high relapse rate. Like once you kind of discontinue the naproxen, not uncommon that things are going to flare up again. Then we move on to second line treatment. So I will just say also though, if you start out with vertebral involvement, we do not stop at NSAIDs. We definitely don't feel that that's sufficient, and we go on to second line treatment no matter what. So the second line treatment is a little all over the place because of this being a fairly rare, not great studied treatment. There's very little comparative evidence. There's no prospective randomized trials to tell us what to do. It's all based on like case series and observational retrospective studies, things like that. So you end up having three choices, really, like three categories to choose from. Our classical DMARDs like methotrexate, our biological DMARDs like TNF inhibitors, and bisphosphonates. And here at GEO, we tend to use zoledronic acid. Some places do use permethrinate. This is not something that you guys, hopefully, unless you go into rheumatology, will necessarily need to know more about, but just for you to be aware that these are our choices. And sometimes, you know, not clear what to use. But what they do say in the latest kind of review paper is that if you have a patient with lots of bone lesions and actually like high systemic inflammation, then maybe a TNF inhibitor would be a better choice. But if you have vertebral involvement, especially compression fracture, then this.
Do we use the NSAID?
Yeah. You got it. Yeah, and then outcome assessment is really, really hard. Like really hard. They came up with this clinical disease activity score, which is such an oversimplification because these patients, there's a very high proportion of them that end up with almost like fibromyalgia, like amplified pain, because of just their pain sensitization increases so much with this condition that for a patient to have a pain VAS of 0 is like very hard. I would say very unlikely. Same with their global assessment. And then you'll see number of clinically active lesions. So that is the other tricky part. Because if you do imaging and you see 10 lesions, but they only have pain in 1, it's like kind of counterintuitive to think, oh, those other lesions don't matter. But at this stage, at this point, unless they're in a physiologically sensitive area, we don't treat asymptomatic lesions. I just find it hard though, because you could have an MRI lighting up everywhere and you're just like, it's okay. And it's hard for families to grasp that too.
Do they know if those regions affect like growth and stuff like that, even if they're not?
If they're like epiphyseal and they're causing like limb length discrepancy, then yeah. But it's not that obvious. It's not always that obvious. So it is hard. Okay. So back to the case, because I kind of want to show you guys what a typical journey and how it sort of all comes together. So you remember back, it was our 9-year-old boy, hip pain, then also knee pain, couldn't play hockey anymore. We found all those lesions. What you do? What would you do now that you know a little bit about CNO? Poor boy can't play hockey. Yes, of course. That's our easiest thing to do. So 100% start naproxen. Can't go wrong. Unless he has IBD, then you're going to go wrong. Yeah. But, you know, we're just hope he doesn't. Yeah, no, you're going to screen him for IBD. Yeah. Okay, what else? What else are you going to do? You're going to leave him there? Yeah, 100% physio is involved. But also from a diagnostic, because if you remember, we have bilateral hip MRIs. That's what we have.
The body MRI.
Yes, the full body MRI. He already had some blood work done. Yeah. Okay. So lo and behold, this poor child did his whole body MRI, and he actually had high signal intensity in his T12 with an compression fracture. So, and then we found more lesions. We found more lesions in his proximal tibias, left tibial metaphyses, distal left tibial metaphyses, and left calcaneus. Okay, what are you gonna do now? Yes. Okay. Oh, sorry. You're gonna see him again. Yeah. I usually do. Yeah. I usually do. Sorry. So you do want to obviously clinically assess them again too. And he had this weird story when I saw him again that someone pushed him down and then he suddenly had severe back pain. And I was like, is that just a red herring? Or is that actually when he had a fracture? Like, I don't know. But then it improved. Like by the time I saw him, it had improved. And he felt overall better since starting the naproxen. He was back to soccer, but not hockey. But yes, we initiated treatment with zoledronic acid. And protocol we use here is we give 3 doses 3 months apart. And then we repeat imaging. He did stay on naproxen though, and then we did the physio. So when he came back after those 3 infusions, he still had pain, fortunately, to his sacral spine and left ankle. He was playing hockey, but not to the point that he wanted to play, and he was really relying on naproxen. What would you do now? But using biologics, okay, is there anything you would do before you make that final just to give you yeah, so we tend to repeat the imaging before kind of making a big treatment change, because as you know, as I mentioned, it can be hard to clinically assess these patients, right? To like tease out if their symptoms are due to bone inflammation or not. So we did repeat his MRI. And actually his vertebral lesion improved dramatically after the zoledronic, which is really good to see. But then he had a lot of hyperintense signal around his sacrum. So that probably correlated with his symptoms. Again, also in the right acetabula, and then he had left tibial calcaneus, left medial malleolus. The intensity at the calcaneus had improved. So some things had improved and some things weren't. And I find these MRIs are really hard to interpret sometimes, but then you have a conversation with the parent and child and try to do your best to correlate that to their actual. So then, then we said we should try an anti-TNF treatment. So he started on adalimumab. He had this initial really good honeymoon period, like good response, and then his symptoms all recurred. And so I was like, oh, let's just try increasing the dose or increasing the frequency to every week. And we just did that in September. And I talked to the mom like the other day, and he's actually, oh, they are thrilled. We'll see how long this lasts. But, and then she was able to wean his naproxen to once a day, which is also a big deal because he hadn't been able to do that. So fingers crossed. Yeah. So that's where we are. So in summary, can result in kind of waxing and waning MSK pain, which may be worth activity. That's an important point to drive home. It's a diagnosis of exclusion, but we do have these new classification criteria that can help you. We rely heavily on MRI. If you have any diagnostic uncertainty, atypical lesions, then a bone biopsy is warranted. And then the treatment approaches starts with NSAIDs and then considering bisphosphonates or anti-TNFs. For vertebral lesions or refractory disease. And that's it.
Finish the childhood, if it's something that they,
Yeah.
Get
So the natural history is thought to be that it does burn out over time. Because I don't follow these patients into adulthood, I don't have a lot of personal experience to go on. It's just what's reported in the literature. But they do say if you did absolutely nothing, it would burn out. As far as how long to keep them on therapy, no one knows the answer to that. We're like barely at the point of like making therapy guidelines, never mind how long to keep them on, when to repeat imaging. Like the other problem, we just had radiology rounds on Tuesday, like these lesions on MRI, they gave me lag for a long time. Like that's the other trouble is like they're saying there's bone marrow being here. That might not even be relevant anymore, but it's still even on the MR. So there's a lot of difficulty with making those decisions. There's a lot of clinical judgment. Like generally, I would say I'd like to keep them in a remission state for at least a year, ideally off naproxen, off NSAIDs, before I would do anything. But I'm basing that just on.
Yeah. How long of a course do you get their protection? And yeah, like if we prescribe it for like 2 weeks for a kid, do you actually need it or?
Yeah, good question. I would say if I know that's going to be my mainstay of therapy long term, I will prescribe gastric protection. I don't know if there's actual evidence. If it's more of a like bridging situation, then I might not. What I often will do is I'll send the prescription to your pharmacy. If you run into trouble, fill it. But I won't necessarily prescribe it up front. Questions? How about from online folks? Any questions from you guys?
No, thank you.
I'm gonna log out of the Teams meeting because the next presenter will log in, okay?
That sounds great.
Okay, thanks.
Everyone could sit down. We'll get started. How many are in a room with a whole bunch of pediatric residents? Oh my gosh, I love that. Hi, my name is Dr. Alexis. I'm pediatric palliative care physician. I'm going to sit down because we're here for 2.5 hours and we're all about sustainability. Hopefully we finish earlier is my hope, because I think I'm the last lecture before lunch. And by last lecture, also the second lecture of the day. So we're in for a bit of a ride. I apologize if any of the information that you get is repeat. Please feel free, if anything is like, wow, we've done this already, just like give me a signal in the background, and we can speed through some of the different things. Hopefully everyone online can hear me. Send a message if you have any issues. And hopefully I will see it. I'll try and keep an eye out. And so today we'll be talking about end-of-life serious illness conversations and symptom management. All good presentations need to start with a meme. It's also very topical because it's October, Wednesday. What most doctors think when they hear palliative care and what actual palliative care looks like. Our objectives today, I went through all the pediatric competencies to see what would be most pertinent for you folks, and this is what I pulled. Neurologic determination of death and principles of organ and tissue donation. Important, but I don't think we're going to have a lot of time today, and I'm hopeful that our lovely critical care physicians will be able to go through some of this with you at some point. But if you have questions, you can also shoot me an email. Otherwise, just general principles of palliative care, including advanced care planning and end-of-life care, establishing patient-centered and family-focused management plans, and symptom management for end-of-life care where appropriate, providing support and counseling to patients and families with chronic illness, catastrophic illness, and/or impending death, provide bereavement counseling, and provide support to families at the time of sudden unexpected death or other crisis situations. So these are all pulled from your pediatric competencies. For today's plan, we'll start off with what is palliative care, scope and review. Hopefully you remember most of this from your boot camp, so we'll try and speed through. Discussions surrounding predictions, prognosis, communication, end-of-life symptoms and management, what to do after someone dies, and case-based learning. Note the content in today's lecture can be heavy. You and I don't share our lived experiences, so if you need to take a break or leave at any time, judgment-free space. This talk this week may be difficult for you, for some of your colleagues, so if you have questions or want to chat privately, shoot me an email anytime. Doesn't look quite right. The fonts are a little bit off because I downloaded it from the SharePoint, which I uploaded to. So you all have copies of these slides. But the prevention, pediatric palliative care is the prevention and relief of suffering of adult and pediatric patients and their families facing the problems associated with life-threatening illness. These problems include the physical, psychological, social, and spiritual suffering of patients, and psychological, social, and spiritual suffering of family members. If we keep having issues with fonts, I'll switch. So it's the active total care of the child's body, mind, and spirit, and support to family. Begins when an illness is diagnosed and continues regardless of whether or not a child receives treatment directed at the disease, and can be provided anywhere. So tertiary care facilities, in community health centers, and even in children's homes. This is Maddie J. Stepanek, a young fellow with a neuromuscular condition who has now passed away, but was very involved with a pediatric palliative care team. And he wrote a book called Heart Songs that has poetry and stories about his journey. And he said, palliative care no longer means helping children die well. It means helping children and their families to live well. And then when the time is certain, to help them die gently. In terms of foundations of pediatric palliative care, we think of universal or primary palliative care that we should all be practicing. The philosophy of palliative care is something that we can all practice at a hospital level, at a social worker level, like at a family physician level. Anyone can practice the philosophy of pediatric palliative care. Then we have core palliative care services in our hospitals and specialist palliative care. Hopefully you folks have all seen the bow tie model of pediatric or palliative care, showing that palliative care is consulted at diagnosis and is involved throughout the treatment or disease trajectory, either becoming more or less involved towards rehabilitation and survivorship, or to end-of-life care and bereavement. In terms of pediatric palliative care at CHIO, we have a team of 6 MDs, nurse coordinators, nurses, social workers, recreational therapy, researchers, sometimes a pediatric palliative care fellow. We're always looking, and if you have questions about wanting to be a fellow, let me know. For those who I haven't met, I was the most recent fellow up until 4 months ago, so lots of positive things to say. It provides symptom management, end-of-life care, bereavement, serious illness conversations, respite, and ongoing psychosocial support. We can see children in hospital, at Roger Nielsen Children's Hospice, and in homes for end-of-life care. Of note, we had a name change about 2 years ago from Roger Nielsen House to Roger Nielsen Children's Hospice. So who would benefit from pediatric palliative care? I'm going to be really honest with you. The amount of palliative care in your pediatric exam is very minimal. There's not a lot that they test on. It's unlikely that they're going to test on these categories, but it's one of the few concrete pieces of information, and it's not hard to remember. So there's categories 1 through 4, which is how we determine who would potentially benefit from pediatric palliative care. So category 1 are patients who have conditions where curative treatment may be feasible but might fail. So cancer, organ failure, etc. You can see my mouse. You have the child's condition deteriorates at diagnosis, improves with treatment. They might be in remission, and they might continue to be in remission, but they may also relapse, require more treatment, and then are at high risk for premature death. Category 2 are conditions where premature death is inevitable. So for example, Duchenne's muscular dystrophy. Previously, cystic fibrosis was something that used to fall into this category, but with ever-changing medicine and technology, the conditions that fall in these categories are often changing. So we can see that at diagnosis, they have a period of stability, and then as they age, start to have oscillating deterioration and improvement until an inevitable premature death. Category 3 is progressive conditions without curative treatment options. So these are like your neurodegenerative conditions, mucopolysaccharidosis, things like trisomy 18, trisomy 13, where you have progressive deterioration, no curative options. And then category 4 are our irreversible but non-progressive conditions causing severe disability and risk of premature death. So thinking of our kiddos with severe cerebral palsy where they have a diagnosis or insult leading to deterioration, and then may have a long period of stability but oscillations with sickness and illness coming in and out of hospital. They're very fragile and are at very high risk for premature death. When we think of who would benefit from pediatric palliative care outside of these 4 categories, There's not a lot of validated tools in the pediatric population. There's so much in the adult side, not a lot in peds. So one of the things that we like to use is the surprise question. So asking, would you be surprised if the patient died in the next 12 months? If you would not be surprised, they're probably a good patient to be referred to pediatric palliative care. There's also the pediatric palliative screening scale, which I've included, but is not routinely used. It's a validated tool. It's essentially a long questionnaire. We don't use it here. You don't need to know it, but I've included it for completeness sake. So predictions, prognosis, and communication. As I'm sure you folks are aware, we are so awful at predicting trajectory of illness. There are a lot of different things that we can use to help get a better idea or, guess, but our crystal balls are so fuzzy. Like we can't tell, for the most part, how long someone is going to live for. We can look at their illness trajectory based off of different illness types. We can look at those categories, category 1, 2, 3, 4. What can you expect with your specific illness? And there are certain tools for different specific diseases, but unlike the adult side, we don't have like an all-comers general calculator or tool to say this person is at high risk for death. Again, there's a surprise question. It's highly sensitive for identifying individuals who would benefit from referral. In one neonatal study, around 30% of infants who physicians expected would die in the next 12 months died, and only 0.5 of those who were not expected to die died. So not great. That's still 70% of individuals who lived, despite people thinking that they may die. But you can certainly see that some of that insight does prove effective in terms of the difference of the 30 to 0.5%. Again, not many great generic pediatric prognostic tools. And often it's a unique patient trajectory, and it's utilizing lots of different pieces of information unique to that patient. How many times have they been to hospital? What are their comorbidities, etc. A lot of the adult tools as well are typically created for like a specific disease. And a lot of the patients that we follow have so many comorbidities, none of these tools really tend to fit well for them. So in terms of introducing palliative care, the earlier is better. Ideally shortly after diagnosis. There's so many misconceptions, misnomers, preconceived notions about what palliative care means. It is not exclusively end-of-life care. The best time is as early as possible. And so when you're introducing palliative care early, like a script of what you could say is, one of the teams we often introduce early is our pediatric palliative care team. This is a multidisciplinary team that provides support throughout the illness trajectory and is consulted as a standard of care for any patient with a serious or life-threatening illness. This team works with the medical team, not instead of it, and can help manage complex symptoms, provide respite care, and also help support challenging decision-making. Many people associate palliative care with end-of-life care. While the palliative care team does support children at end of life, it's an important part of the work that they do. It's not the reason we're consulting them today. Often as patients grow or stabilize, the palliative care team may sign off as well. And this is not to say, sometimes we are consulted at end of life, and I think it's important to acknowledge that, and we'll go through that next. So an example of how you can introduce palliative care in someone who is critically ill is, we know that Johnny is very sick. I am worried that Johnny's illness may not get better and that Johnny will die. We're continuing to do everything we can to support Johnny, but as we do so, I'd like to introduce your family to the palliative care team. This is a multidisciplinary team that provides support with active symptom management, and they're experts at helping navigate difficult decisions and understanding your family's wishes, goals, and hope. They work with the medical team, not instead of it, and they're an extra layer of support for both the family and the medical team throughout whatever may come next for Johnny. My hope is that Johnny gets better, but I am worried and want to make sure that we involve all the necessary supports and information to inform next steps. Oftentimes, when you introduce palliative care to a family, you're going to get a reaction. Oftentimes, people might be shocked, might be upset, might look scared, might become quiet or combative. I think it's important to acknowledge the emotion that you're seeing. This is the nurse protocol or guide framework for acknowledging and responding to emotional aspects of patient communication. So if you notice the shift in tone or emotion or reaction, don't ignore it. You say, I noticed that there was a shift in tone when I mentioned palliative care. Can you help me understand what you're feeling? Because again, a lot of folks have an understanding or experience of palliative care that is typically end of life. And I think that's really scary and important to acknowledge the fear and the uncertainty and try to take uncertainty away where you can. And then again, you don't ask a family if you can consult nephrology. We shouldn't really be asking families if you can consult palliative care. A lot of families will just say no if you ask. We are a standard of care, and it's important to involve the palliative care team. Models of communication, you're going to have another lecture at some point through the palliative care team for serious illness conversations. So we won't spend a lot of time on this, but just a quick review of some different models of communication. You have your spike, setting, perception, invitation, knowledge, emotion, summarize. I hope you've all seen this at some point in medical school or heard of it. The I wish, I worry, I wonder framework, which I really like. It's really easy to remember and is really helpful for aligning with patient hope, family hope, acknowledging their concerns, and allows you to propose a way to move forward. So saying, I wish allows for aligning with the patient's hopes. Saying, I worry allows for being truthful while sensitive. And I wonder is a subtle way to make a recommendation. And then there's a serious illness conversation guide, which also utilizes the I wish, I worry, I wonder, I hope framework. At some point, you folks will all go through training and how to utilize this. So in terms of models of advanced care planning, we'll quickly review the CPS statement because that's definitely testable material for your exam. And it's actually not bad. So we'll do that and then we'll chat about what advanced care planning looks like at CHEO. So this is the CPS statement. I have a QR code here for the actual statement. Again, I've uploaded the slides to your folder, so you should all have access to it. They define advanced care planning as the extension of usual discussions about the future, typically for patients with a serious illness that focus on possible medical needs as things change, and they're rarely a single event, but conversations over time. So if there's one thing that you take away from this CPS statement, it's that these are conversations that are important and should be destigmatized. I think that people are often scared to have them, but they are so important. And the more often you have them, the less stigma there is and the easier it is to plan for the future. It's so much easier to have these conversations in clinic than doing it in the ICU when someone is actively deteriorating. Their approach for advanced care planning conversations is fairly simple or can be simplified down to ensuring understanding of the family, exploring what matters most, and then recommending a treatment. They break down goals of care categories nicely into interventions that prolong life, interventions that would provide as much good time as possible, and then interventions that would focus on comfort. Oftentimes, there are interventions that may not fall cleanly into each of these categories, but it's a nice way to visualize, especially for families, and aligning with what their goals are. When should you have advanced care planning conversations? The CPS statement says that they're most often triggered by admission to intensive care, but again, should be initiated early in the disease course, ideally shortly after diagnosis or even before birth for our prenatal families, to understand beliefs, wishes, and values. And then again, periodically revisiting, especially following significant changes in health status or major life events. Again, early conversations help families to reflect on difficult subjects from a safe distance. The people who are involved should be the individuals who are responsible for making the healthcare decisions, but including the child if it's developmentally appropriate. some parents are fearful of including their children in these discussions, but it's important to explore with the parents what their fears are and, if developmentally appropriate, whether the child wants to be included in these conversations. So some children may really want a say in their care and planning moving forward. Some children may not. Some may want a broad overview. Some might want like nitty-gritty details. So important to explore with the family and the child. And then these are the summary recommendations from the CPS. So healthcare providers should initiate conversations about goals of care and advanced care planning, start early in the disease course, especially for those who have a shortened lifespan. Healthcare providers should assess patient and or parent readiness to engage in advanced care planning. Signs of readiness might be verbal, like, I don't ever want to go back to the ICU again, or something's different, you've lost that spark, or nonverbal, i.e. the patient can no longer do the things that they love to do. Unless urgent decisions are needed, it's important that we respect families and their wishes to delay conversations about the future, but ensuring that you have an agreement that you're going to check in again at a later date. The healthcare providers who have a trusting relationship with the child and family should be continuously involved in these discussions whenever possible. So palliative care is always going to be there to support you no matter what, but sometimes the best person to have a goals of care discussion is the individual who the family has built like rapport and a relationship with. Like, we are always here to help, but it can be really challenging to swoop into a room or be consulted, meet a family for the first time, and then explore what their goals are in a child who's critically ill. So of course, we will always help, we will always support, but just reflect on the relationships that you have with these patients, and that sometimes their general provider or someone who's known them for the longest is kind of the best person to initiate these conversations. And you can always be present to help facilitate and support those discussions. Like, you don't have to do it by yourself. Again, emphasizing the primary goal of these discussions is to engage patients and families with conversations about what matters to them, and specialist pediatric palliative care teams are available and can help support. When it comes to advanced care planning at CHIO, we'll just quickly go through some terminology. So there's the ACP and the PCD. ACP, the Advanced Care Plan, as per previous definitions, is the conversation surrounding goals, values, and beliefs as it pertains to a child's medical status. The PCD is the Palliative Care Directive, and it's a formal process used only by the palliative care team to review goals of care and advanced care planning on a yearly basis. This includes a form and epic, multidisciplinary meetings with nurses and social workers. So it's a piece of information, but it is not necessarily like the first place to look if you're looking urgently for goals of care. So this is an example of an epic page. If they have goals of care on file, you'll see beside code, it says ACP on file. If you hover, they'll have all this information. The most important part for you, particularly in an urgent situation, is this last ACP note piece. That will be a very succinct, quick, simple way of saying, do they want CPR? Do they want intubation? Do they want to allow natural death? You will see that there are some scanned palliative care directives, the PCDs, and those are, documents that the palliative care team uses. You can always take a look at them, and we'll look at them on the next slide or in the following slides. Sorry, the screen is a little bit off from what's on my computer. And so you can see at the top here is where the advanced care planning notes are. If you have a goals of care discussion with a family and you want to update the ACP, this is where you click create ACP notes. So you get to this page by clicking on the code status or the ACP in that previous page by clicking here, ACP on file.
Can I ask a question?
Yeah.
One of the things that we get asked to do, I would say not infrequently in PCU, is can you guys document code status? It's not in the chart, and so it's important for nursing staff. Blah, blah, blah. I never feel comfortable documenting anything that I've just been told is conversation that I was involved with the family directly, like, what do you recommend in that case? Like,
I
would
would,
never write an ACB note unless I
Yeah.
actually had the conversation.
yeah, I would say that if you weren't there, I also wouldn't feel comfortable writing the ACP note. I would just respectfully ask the person who's asking you to do it, like if they were the ones who had the conversation, see if they know how to write an ACP note, because oftentimes like a lot of the staff don't actually, and so offer to walk them through the process. Very respectfully. There is a policy that's coming out that should like clarify this, so there really should be no room for people to say or staff to say that they don't know how to do it anymore. But I wouldn't write an ACP note if you were not there. No, that's totally fair. I would absolutely support you in not writing the ACP note if you are not present for the conversation, because that's the note that's going to guide what people do in an emergency and parents aren't there. And so if you're the one who signed the note, like it like you wouldn't ever write a note, right, for something else where you weren't there or weren't present. It doesn't make a lot of sense. So respectfully offer to show them how to do it. So you can do it by clicking on create ACP note. Again, we want short, succinct, something that someone in an emergency can hover over the ACP code status and see exactly what their code status is. What's next? If they have not had a code status previously, after you put in the ACP note, you have to put an order in for ACP on file, just so that it pops up on that left-hand side. And then the bottom half of the screen, like you don't need to know too much about it. It's what the palliative care team uses. So these are scanned documents of the PCDs that we go over yearly with our families. Down here is just where we input the information. And this is what a PCD form looks like. So it is like very nitty gritty, goes from the most simple diagnostic test to like CPR, and we kind of review it on a yearly basis for anyone that our team follows regularly, just to create a framework for some of those discussions. We always tell families that this document is a framework. It's not the end all be all. In an emergency, we're always going to try to contact the family first, and we're not going to look at this and blindly start dialysis without talking to the parent or guardian. And then just going back to the ACP notes, you can see when the most recent one was. So it's always good to look at the most recent. In the actual, like when you hover, the most recent one will always pop up automatically.
For this.
Yeah.
PCD, like the wording is like this for treatments, interventions desired.
Mm-hmm.
But then you have some instances where the medical team is, you know, not gonna offer that. So how does that get stopped?
So for this, like you folks will never have to input anything into this form. This is just when we have like our yearly meetings. They're never like in the ICU with that Roger Nielsen Children's House with coffee, social workers, recreational, like in a very relaxed environment, just to get an understanding of what families' desires are. Like you would document in an ACP if you would not offer a certain intervention. And we'll talk about CPSO protection and not offering treatments in a little bit. If you have a really thorough, in-depth conversation with a family, important to document it in a separate note, and then have this thing to like ACP, like 3 to 4 sentences in the ACP note. Because often our discussions are not like 3 minutes long with families. Often there's a huge amount of information, desires, hopes, worries, goals that are discussed. So just include that in a separate note, and then your like definitive ACP in the ACP note. And then just tools and tips for anyone who does not have like ACP on file. You can search goals of care, ACP, death, dying as keywords to see if there have been conversations in the past that might not have been documented into an ACP. Again, sorry for the font. In terms of cardiopulmonary resuscitation, I just wanted to quickly touch on some of the numbers and beliefs that our families have. There are a variety of things that we could talk about when it comes to advanced care planning, but I'll talk about, like the most invasive being intubation and CPR. So our families often, and people in general, tend to have a much more optimistic outlook on CPR than what is actually accurate. So there's not a lot of studies looking specifically at parents, but an adult study in the US showed that the mean estimated survival rate by the general public after cardiac arrest was anywhere from 54 to 75%. So most adults in the US thought that after someone gets CPR, their survival was likely to be anywhere from 50 to 75%. A study in Switzerland showed that only 9.3% of older individuals correctly estimated survival to hospital discharge after out-of-hospital CPR. The actual numbers are significantly different. So out-of-hospital cardiac arrest survival to discharge is anywhere from 6 to 13%, and in-hospital cardiac arrest is 32 to 45%. These are all-comer numbers, and I think it's also worth just keeping in the back of your minds that this doesn't take into consideration like our complex care families who may be CPR trained, or patients who have multiple comorbidities and are at higher risk. So you're also getting like the generally healthier kids who have cardiac arrest as well. And interestingly, there's a lot of thought that mainstream media is to blame for like this really positive outlook on how survival for CPR is, because we watch these movies and everyone survives for the most part. So very different to real life. And it's important that when we're having these conversations, parents understand what CPR looks like and what outcomes actually are. So this is referred to as a deuteriograph. Again, this is not testable material, but it's helpful in having conversations with families, looking at a child's condition over time and seeing when CPR is given. Parents often, their expectation of CPR is that it somehow restores health. So often parents have this magical thinking that after CPR, it's going to reset things. They're going to go back to a healthier place than they were than before they got CPR. When in reality, when you get CPR, we're zooming in here to the minutes before CPR was given. And that's really your trajectory when CPR is not indicated, or sometimes, even worse than when CPR was given. So important to, again, clarify with families their expectations surrounding CPR. Consider the language of protection for a child instead of the language of withdrawing or withholding an intervention. And so protection against interventions that might not provide meaningful time or comfort, or interventions that may ultimately cause suffering. So I have another QR code. I have lots of QR codes, but again, you have the slides. I've included all the information regarding CPSO protection surrounding physicians not offering a treatment. And so this webpage, or the CPSO, kind of outlines the responsibilities of the physician in these circumstances. So it is the responsibility of the physician, where appropriate, to initiate discussions surrounding advanced care planning. It is the responsibility of the physician to initiate timely goals of care discussions. Physicians must balance medical expertise and patient wishes, values, and beliefs when making decisions about end-of-life care. And physicians must obtain consent from patients and/or substitute decision makers before withdrawing life-sustaining treatment. This doesn't always happen. Not infrequently, there's disagreement. In that case, you get second opinions, ethics consultation, and if you're unable to come to agreement, consent and capacity board. When it comes to withholding resuscitative measures, they say a physician's decision to withhold resuscitative measures is not treatment, and therefore does not require the patient or SDM's consent. They say where the risk of harm associated with resuscitation outweighs the potential benefits, physicians may decide it is appropriate to withhold resuscitative measures and write an order to this effect in the patient's medical record. So you must, these are the things that they say you must do, is your responsibility to do. You must consider patient wishes and personal, cultural, religious, spiritual beliefs. You must inform the patient and SDM that the order will be written. You must explain why those resuscitative measures are not appropriate, and you must provide details regarding clinically appropriate alternatives. If the patient is deteriorating imminently, you can follow through with these steps at the earliest opportunity. But this is also to say that there is protection for withholding resuscitative measures like CPR if the medical team does not feel that it is indicated. And again, not testable material, just super helpful to know, especially where you folks are on call, you're in the ICU. There will be patients where the family wants CPR, but the medical team does not feel like it is indicated. Make sure that you talk with the physician beforehand when you're on call to ensure that the family has an understanding that CPR will not be offered, to give yourself peace of mind and to make sure that you're planning appropriately for your call shift, because it's really stressful knowing that parents want CPR, but it is not medically indicated or going to be offered by the medical team. In terms of goals of care, we also have DNR-C forms, so do not resuscitate confirmation form. It is a form that provides an extra layer of protection for a child or family when CPR is not recommended by a physician or desired by a family or patient. I don't know what that sounds like, but I hope that it wasn't someone online. We encourage people to keep the form with the child, though this can be really challenging when kids are going to school, going to the park, really challenging. Parents don't need to sign it. It's just a healthcare provider, and it's to be presented to paramedics in the event of an emergency so that CPR is not done. However, parents have the option to choose in that moment to not give the form, and that's okay. Again, once it's signed, parents are not obligated to use it, but it's an extra layer of protection against an intervention that could potentially be harmful to their child. This is what it looks like. You get them from the Ministry of Health, like you have to order them because they all have these serial numbers in red at the top. So I would not like get one and then photocopy it and use it between patients. You can photocopy the form, but it has to be for one patient only. Usually if they have a DNR-C, it's typically from our team, and we'll upload it as like a scanned document in the chart. But again, we're going to reflect it in the ACP as well. And then you can see that there's a spot to sign for like the care provider. Parents don't need to sign, and there's two options: either the current plan of treatment that reflects the patient's expressed wishes when capable to not have CPR, or the physician's current opinion is that CPR won't be useful. That's usually the box we check. In terms of locations of care, we've kind of touched on this already. It can be hospital, it can be hospice, it can be home, it can be anywhere in between, can transition from one place to the other, all depending on the family's goals, their symptom management needs, etc. More often than not, people choose to be in hospice or home, but sometimes for our families who have been in and out of the hospital for so long, like sometimes our oncology patients in particular will choose to stay in hospital because that's where they know the nurses, that's where they have relationships, and that's where they feel comfortable, and that's totally fine. We'll talk about symptoms at end of life next. Do you think folks think that you would want to break at the 1 hour mark, or do you want to like speed through and try and get through as much as possible so you can leave for lunch early?
Like a break.
Okay. We'll do a couple of minutes of symptoms at end of life, and then we'll take a break in about 15 minutes. So when I think of symptoms at end of life, I like to think from head to toe, to think of what to expect with any given illness trajectory. So we'll kind of go through all of them. I've included like extra information. Again, on your final exams, you're gonna have one, maybe two questions top on palliative care, and they're gonna be like simple questions about like treating pain. Like you're not going to get any questions about managing refractory nausea and vomiting in a patient with mucopolysaccharidosis at end of life. Like it's not going to be that, but just so that you have these slides and this information. So starting from head to toe, thinking of, the CNS system, altered level of consciousness. So decreased energy and altered LOC is common and to be expected and should be a part of anticipatory guidance. If it's primarily a concern of decreased energy and it's really distressing to the patient, you could consider stimulants, but it has to be goal directed. So I would not start stimulants in every single patient who tells me they're tired at end of life, because it can be distressing. Like it can have side effects, like you're awake, but you're experiencing all of these other symptoms of pain, discomfort, nausea, vomiting. Like it needs to be goal directed. So saying like, I'm really tired and I really wish that I could just stay up late because I enjoy baking at night with my family. That is something that I would start Ritalin or bifenton for. Delirium is also very common at end of life. Common causes include brain mets, other brain pathology, hypercapnia, medications, fatigue, electrolyte abnormalities, pain, sepsis, so many different causes, so many causes that overlap with the causes of what is going to cause delirium in your ICU patients as well. It's often underdiagnosed, so should be carefully screened. Common screening tools include the Cornell assessment of pediatric delirium, is my personal favorite. Mainstay, as you know, for your ICU patients, for example, is non-pharmacologic management first and addressing reversible causes if possible. So non-pharm, familiar people or toys present, low lighting, appropriate daylight exposure, trying to maintain correct sleep-wake cycles, minimizing restraints and painful procedures or stimuli, and then pharmacologic interventions if the risk of harm to self, if there is risk of harm to self or the patient is experiencing distress. So for hallucinations, we might consider antipsychotics or harm reduction with sedation with benzos or phenothiazines, atypicals with strong sedative effects. Again, for testing purposes, at most, you could say hallucinations, consider antipsychotics. But truly, if a patient is delirious at end of life and they're picking things out of the air, but they're comfortable and content, I wouldn't treat that, assuming there are no reversible or easily reversible causes. Other CNS symptoms are seizures, which are also a surprise, very common, particularly in those with underlying seizure disorders, brain mets, electrolyte abnormalities, and increased intracranial pressure. Please continue their AEDs. At end of life, if someone has been on seizure medication for forever because they have seizures, oftentimes it's common, and I've seen commonly people culling the list of all the unnecessary medications. Please don't stop the anti-epileptic medications. Having seizures, generally not the most pleasant experience. And so leave their anti-epileptics on at end of life. We can increase the dose if need be. We can add adjuncts if they're not taking medications orally. We can always switch to IV, IM, sub-Q routes, or can escalate to infusions. And then for severe refractory seizures, we can do palliative sedation. We'll talk about palliative sedation at the end. That's last possible step for refractory symptoms for really anything. But again, we'll touch on this later. Going down the body. So I'm thinking CNS, and then I'm thinking ENT, ears, nose, mouth, throat. When I think of ears, nose, mouth, throat, I think about secretions or lack thereof. So oral secretions are common at end of life due to impaired swallowing, may sound noisy because of relaxation of the tissues in the oral pharynx. Sometimes people refer to that noisy breathing as the death rattle. We don't refer to it as the death rattle. I like to think of it as them being really relaxed. They are by the time that they have all the secretions and are breathing like that and have impaired swallowing, they're usually not aware, and so they're not distressed by it. So I explain to families that sound is because they're not swallowing their saliva, it's pooling, and all of the muscles in their head and their neck are starting to relax, and that's what's causing that gurgling. So it can be really distressing to families. So anticipatory guidance and reassurance is key. If there is a lot of secretions, you could always consider postural drainage, so like having the head turned to the side to allow it to drain out of the mouth, reducing any interventions that can contribute to increased secretion. So, for example, like if you're had lots of nebulizers going, you might increase like condensation and secretions in the mouth. And then you can also reduce or decrease or withdraw artificial hydration or nutrition. Typically, pharmacologic interventions are our anticholinergics like atropine, scopolamine, glycopyrrolate, but they're like so notorious for causing delirium and should really only be utilized if the patient is distressed by their secretions. So when families hear this like gurgling, noisy breathing, I will say that often, like I liken it to snoring. I'll say like, oh, do you have anyone at home who snores? Often the person snoring is completely like at peace, so comfortable, and it's everyone else in the room who's bothered by this like noisy breathing. And that's similar to how it is at end of life. If they're really worried about distress, like I tell families, like, look at their face. Does it look calm? Are they grimacing? If you think it's from their secretions, you can always try an anticholinergic, but I would always encourage you at end of life to consider, like, are we treating the patient's symptoms? Or are we treating our distress and the family's distress? And then suctioning can cause trauma, additional distress, and paradoxically increase saliva production. On the other hand, lack of secretions is really common, xerostomia. So dry mouth can be quite distressing and is also common at end of life. Important to review medications and discontinue anything that could be contributing, like our anticholinergics. Like many of our complex care kiddos are on like atropine for secretion. So just reviewing what medications they're on, ensuring if they are getting some form of oxygen that is appropriately humidified. You can use artificial saliva. It's often more used in the adult setting. I feel like children hate it, and I feel like don't really blame them. It also doesn't like sound the most pleasant. Alternatives that are more like pediatric friendly are sucking on ice cubes, good oral hygiene, small sips of liquid. You can also use wet sponge tips in the mouth. Also chewing gum, sucking on candies, watermelon. There are studies that show watermelon is great, or sour candies. So much more, so much better sounding than artificial saliva. And then we'll talk about breathing changes, and then maybe we'll take a couple minutes of break. So going down from head to toe, I've thought about ears, nose, throat, and now I'm thinking about the lungs. Again, we've talked a little bit about that noisy breathing at the end of life. We don't call it the death rattle. Families may refer to it as the death rattle. That's fine, but we don't use that language. So there are a lot of different changes in breathing patterns when someone is approaching end of life. One of the breathing patterns that we talk about is Cheyne-Stokes breathing, where you'll have gradual hyperpnea and then periods of apnea, often due to decreased cerebral perfusion or oxygenation, brain injury, etc. When I talk to families, I don't call it Cheyne-Stokes breathing. I will say it's really common at end of life for people to have changes in the way that they breathe. Some people breathe faster. Some people breathe slower. Some people will often start to have long pauses in between their breaths. So they might take a big breath before, and a long pause before they take their next one, where they sound like they're gasping. And oftentimes these pauses become longer and longer until there's not another breath and the person dies. So again, these breathing changes can be really scary for families. And so just providing that anticipatory guidance, being calm, providing reassurance. Apneas can also last a shockingly long time. So it's not uncommon for families or loved ones to be sitting there waiting, counting for the next breath, wondering if the patient has died yet. Particularly in babies, apneas can last like minutes and minutes and minutes and minutes. So we'll talk about this later, but when someone dies, like there's truly no rush, particularly for babies. Like I can assure you that we've been called for babies to pronounce death and they start breathing again. I can also confirm that this has happened for like 8-year-olds on the ward. So we'll chat about this later, but when someone dies, there's no rush to go prenatal. But yes, apneas can last a very long time, and so just providing reassurance to families. And then sometimes a person will have a pattern of agonal respirations, like those like big gasping respirations, sometimes referred to fish out of water breathing, which again, we don't refer to it as that with families. They may say that, but we just call it, I wouldn't even call it agonal respirations with families. I would say just breathing changes at end of life. But it's a brainstem reflex characterized by those gasping, labored breaths, and may accompany vocalizations or like myoclonus or like increased tone. Despite like all of these names, it's not uncomfortable, but can be really distressing to families. So just to provide anticipatory guidance. I think this is the last one for lungs, but is dyspnea. Dyspnea is the perceived or subjective sensation of difficulty breathing, air hunger, etc. It's really hard to define, pathophysiologically really complex, not well understood. It's not simply just the level of CO2 or oxygen in the blood or acidemia, and it's not work of breathing. So you could have people who look horrendous and look like they are struggling to breathe, but might say like, I feel totally fine. So they're not dyspneic. Whereas you might have people who like their blood work is totally normal, but like feel like they're short of breath. That is dyspnea. So really, dyspnea is subjective, and we can only really tell someone is dyspneic by asking them. A little bit more challenging in our nonverbal population. And so just kind of reading their cues that the family has learned over the years for when they're uncomfortable. Determining whether it's dyspnea or not, though, is much more challenging in our complex care population. In terms of management, takeaways or things that are like testable, which again, I don't think you're going to get questions on this for your exam, but like easy things to remember for dyspnea in palliative care is non-pharmacologic measures like a fan across the trigeminal nerve or just like across the face can be really helpful. Studies have shown that oxygen is not shown to help dyspnea in studies, but if a patient tells me that their oxygen makes them feel better, I'm not going to tell them they can't have oxygen. But it is like, I would say, testable to say that oxygen is not shown to be like a standard of care for dyspnea. Again, lots of families, particularly complex care families or families who have been in and out of hospital, will be very like preoccupied with SpO2 and their stats. I don't like at end of life, I don't really care about their stats that much. They're not that accurate, particularly because like kids are like at end of life model, their perfusion is that it's not gonna be accurate. So I don't care about the SpO2. I care about what the child is showing me and what they're experiencing. So opioids are the mainstay of pharmacologic treatment at usually 1/4 to 1/2 the starting dose of analgesic dosing. And then benzos will not help on their own, but are like a good adjunct to opioids. And with that, maybe we will take a pause for like 10 minutes until like 10:32, and then we'll restart. Okay.
I'm like, oh my God. I was like in my car and we driving back like this the thing and text me and like really kind of friends but like we'll check in every few months. And he goes, hey, what's up? I'm like, what's going on? And he goes, I mean, I have some news. And I'm like, I think I know what this is, but like he sent me, it was like sent you a photo. And I'm like, I can't look at the photo right now, but I sent you a sonogram and he goes, yes, it is. And I'm like, the other day. I am. He's writing it. And the baby was here all the time. I'm like, good luck. Oh, yeah. Oh my gosh, that's a lot. Like my kids, that's what next to me. Yeah. Yeah. So it's my like friends like together for years. But anyway, it like someone brought up the idea, and then I was kind of like, I can maybe make that work. And then I was like, this might work. And I was like, well, I'm never gonna get to do this again. Literally, like 8 of your closest friends are like, the thing is like. There's like couples, and then there's like me and Matt. And like, my God, we talk from together. I'm like, no. I'm like, one, long time. Like, no. And then I'm like, if by chance, then I have to do my life. Like, that should be anyway. It all worked out. Like, I got a couple things for helping him. I got 2 dumpsters so that one of the companies is gonna split. So like, be with the girl again, I'll be again. And then they're gonna trade halfway through the trip so that not one person is not with their significant other, whatever. And I'm like, there's literally a group of friends struggling, not supposed to be your roommate. It's something cool. Yeah. Anyway, everyone's cool with it, but the one cool that just got married, and I think they're like making it pseudo but it's gonna be fine. I don't know why it took that long. I'm not. And then my friend just recently through translation like got a group deal, like it's officially booked. We booked the deposit, and then I just got an email from Brittany last night being like, your date's been approved. I'm like, blessed. Because if you said no, I don't know what to do. Yeah. They're not bad. That. Yeah. It's on service. I was a little nervous because so it actually how we're doing it because I already randomly like a million years ago I decided I was going to take a random vacation day at the end of the week and then an education day on the last day so that I would finish the relationship and then this ended up being the very end of the week going into the first week of and I was like the only thing that made something like that was I have to go to the gym about why I'm actually and I was like literally just taking that for a week. I had research days for the end of the block and like revoke my research days. That's fine. Take them all. And then I was like, you cannot possibly do anything. Still nervous. It's approved, but we will take the research back. Other point of there, I cannot afford to go. All my money is on right now that I've been still paying because we still haven't fixed that issue. And I mean, I'm waiting my dream. On Monday, and like. I was like, I don't need this criteria. I was like, why are they even sending your thing?
All right, folks, let's get started again. All right. So, as we were thinking about our symptoms at end of life, we've gone from head to toe. We've done brain, CNS, ENT, rest system. We can start thinking about like GI. So we'll start with feeding and artificial hydration and nutrition. So I guess a test, like I want to make sure that I'm like very clear about things that are testable and versus things that are just like nice to know for when you're on call. Testable material from this slide being that continuing feeds and nutrition at end of life can actually hasten death and increase suffering. At end of life, you have decreased gastric motility. GI absorption is often slowed. This can contribute to nausea, vomiting, pain. When fluids are absorbed, the body is not as efficient at getting rid of these fluids. So you can have edema, pulmonary congestion, increased secretions, and increased risk of aspiration. In our patients who are able to tell us, we allow them to drive feeding and nutrition by comfort and interest. In our patients who are unable to communicate, we rely on nonverbal signs, feed intolerance, etc. But if a patient is like showing hunger, it's not ethical to withhold feed. Feeding and nutrition is like very intimately tied to cultural beliefs. So how many people here have family members that show their love by cooking or feeding or trying to like force food on you during holidays? Like it's so intimately tied to like cultural beliefs of like love and support. So it's really important to educate our families, particularly at end of life, that those feeds can actually be harmful. So important to provide education and try to reduce harm where possible while being respectful of different beliefs. So you can always consider reducing feeds, but not stopping. You could run feeds as slow as 3 meals an hour and you're still giving something, but it's not enough that it's going to cause harm, or you're trying to reduce harm as much as possible. You could reduce IV fluid by not stopping it, but doing it as minimally as like 2 meals an hour or TKBO. And giving families things that they can do, like using oral swabs to dip in juice, water, pop. Like we often talk about what not to do, but we need to give families alternatives of what they can do. People are often fearful of starving someone to death, and that not eating can be very uncomfortable. It is like at end of life, it is not uncomfortable. Often at end of life, people have decreased hunger cues and are not interested in eating. I liken this to, when you have the flu, you don't feel like eating. You're not interested in eating, and your body isn't able to absorb and utilize those nutrients in the same way. In fact, at end of life, like even if you gave like the best, like at its core nutrients and food, often these patients have like this anorexia cachexia syndrome, so their body will not be able to utilize the food that you're giving them. And so really, again, providing education and reassurance to families. The last point, not testable, but it is possible that you can be really distressed by not being able to eat. Usually that's people who have like esophageal cancers and are like totally cognitively intact and like the rest of their body is okay, but there's an obstruction in their esophagus. Those are the people who become like really distressed by not being able to eat or drink. Very rare in our peds population. CPS kind of had a feeding and artificial hydration nutrition statement, but it's recently kind of disappeared, which is super frustrating for you folks, because I would say like 90% of all the palliative care CPS statements have just kind of like disappeared from their website, which is really rude in terms of studying your exam. But we have the next best thing in the meantime, which is an AAP statement on forgoing medically provided nutrition and hydration in children, most recently reaffirmed in 2024. Again, another QR code, but you'll have access to this. You can Google it. In summary, they provide some cases in which it is ethically permissible to forego medically provided nutrition and hydration. Number one is a competent patient who has refused the intervention. Number 2 is really long and wordy and complicated, but basically when the expected burden of the intervention to the patient exceeds the potential benefit. So for example, in the final dying process where feeding someone is actively going to harm rather than help. And then the third one is in a persistent vegetative state. So this is defined as an individual who is unable to like meaningfully interact with their environment. And that's like providing artificial hydration and nutrition will not meaningfully contribute to their quality of life, and removing artificial hydration and nutrition will not meaningfully impact their quality of life. It's a really long article, but it's a good read. They talk about some ethically more complicated states, like the minimally conscious state, where you are able to like have some type of interaction with your environment, and you might be able to appreciate what it feels like to have a feed, or what it feels like to be hungry, or might not be able to communicate. So ethically, a lot more complicated. Infants with congenital CNS malformations like anencephaly, severe GI malformations, etc. We won't go through with them, or like we won't cover all of them, but like the biggest takeaways for it being ethically permissible to remove medically provided nutrition and hydration, which is a medical intervention. Again, when the patient refuses, when the risks outweigh the benefits, and persistent vegetative state. In terms of other GI changes, there's also nausea and vomiting. Again, also common at end of life, can be iatrogenic from medications, electrolyte abnormalities, gastric hypomotility, obstruction, etc. Our non-pharmacologic interventions include ginger, taking small bites, different individuals like different textures, a lot of education with families and patients, like sometimes kids will want a gigantic like KFC fried chicken burger. Absolutely, I want that for you too, but like small bites, space it out, especially at end of life with gastric hypomotility. Good oral care and hygiene, and then adjusting artificial hydration or nutrition accordingly, or stopping if indicated. I won't spend too long on pharmacologic interventions. Really, it depends on what's causing the nausea and vomiting. A good mainstay is ondansetron, or selective 5-HT3 receptor antagonist. Lorazepam is good for chemotherapy-induced nausea and vomiting. Gravol, Maxaran, dexamethasone is good for bowel obstruction. So truly, like a bit of the kitchen sink, depending on what works for that particular individual. And sometimes some of our antipsychotics as well. Going down the body, we also have bowel and bladder. So loss of control of bowel and bladder are really common at end of life. Constipation and urinary retention are common. Can be iatrogenic or obstruction, thinking of our kiddos with like pelvic masses or like bladder masses. And sometimes it can be really uncomfortable to even ambulate to the bathroom. So thinking ahead of time about like different options that are permissible to that individual. So some people might prefer using the commode, diaper, Foley, like what is the most acceptable to that individual. And then constipation, so common at end of life with that gastric hypomotility. Everything in the body is slowing down. So important to continue to monitor this, as it's a source of pain and distress, especially because they're also not eating as much. So just ensuring that they're having semi-regular bowel movements, or you're keeping an eye on their bowels, because the last thing you want is someone who develops like a bowel obstruction from severe constipation at end of life. And then bowel routine and opioids, non-negotiable. You have to be. And then kind of like the more general, like whole body signs and symptoms, pain. So I think that during
What do you mean by the bowel routine for the opioids?
Anyone who is on an opioid, please have some type of bowel routine. Like if you start an opioid, particularly a scheduled opioid, start PEG. Like absolute baseline PEG. If it's someone at end of life who's not taking medications orally, there are other options like some of our peripherally acting new opioid receptor antagonists that can reverse the action of opioids. But anyone that you're starting an opioid in, if they will tolerate it, which is most of our patients up until the very end of life, is like starting something for their bowels, because opioids will slow your bowels down and you will become constipated. Constipation is one of the side effects of opioids that will not change with time, will not change with dose. It is always going to be there. Other side effects of opioids will sometimes like wear off with time. Constipation does not. So if you're starting someone on opioids, it's like not negotiable. They have to be on some type of bowel routine. PEG is generally like the best one, but also for kiddos at end of life who are not tolerating a lot by mouth, you can think of like Senna or again, like we call them Pomoras. You won't be tested on this, and it's not something that you need to know, but we have the Pomoras, the peripherally acting mu opioid receptor antagonists that are essentially like naloxone, but they only target the receptors in the gut, so they effectively reverse the action of opioids in the gut. It's not first line, so we still do all of our like standard bowel routine, PEG, Senna, whatever first. But if those don't work or the patient can't take medications orally, then we would use those, and that would be naloxegol and methyl naltrexone. You can get both of them. Sorry. So one of them is oral, but it's like a singular tablet. So if they're able to take a singular tablet, that's naloxegol. It's super, super small. And then methyl naltrexone is sub-Q. So you can get both in hospital, but I would always try to get, like if they'll tolerate PEG first. It's really cool. It like the sub-Q methyl naltrexone, most people will have a bowel movement within like 30 minutes of getting it. 6 hours for naloxegol.
I have a quick question.
Yeah.
Like we know that constipation is a side effect for the opioid, for example. Why it cannot the substitute, for example, in a child that is not drinking or eating or for the end of life care, not the standard of care? Because we know the constipation is like a
Why is what not a standard?
why is not the first option the
Methyl naltrexone.
Yeah.
We don't use it regularly. It's still fairly new, and not a lot of studies have been done in pediatrics. So like the pharmacists here are not super, like they haven't used it a lot. When I've ordered it here, I've gotten a lot of calls saying like, have you used this before? Are you sure? And so it's not common. They're still being explored. At end of life, absolutely. Like I would absolutely use it at end of life, but for the rest of the time, which is the majority of the time, you folks will be ordering opioids, definitely, definitely PEG.
Yeah.
So in terms of pain, I think you've had a lecture about pain and opioids in like your peds boot camp, hopefully maybe. But a very common symptom in cancer patients. This is the WHO two-step analgesic ladder. I would say this is something that's testable. There is a three-step ladder for adults, and pediatrics, we use the two-step ladder. So step one is mild pain. We use non-opioids and adjuvants like Tylenol, ibuprofen, Celebrex. And then for severe pain, it's step two, we use strong opioids. And then like the biggest thing I can say just from a practical standpoint is if you have severe pain, like you don't need to give someone, like if someone is in severe pain, you don't need to give Tylenol and then like wait 4 hours, see if it works. Like if they're in severe pain, give them opioids. Especially like if you're giving an opioid naive person a starting dose of opioid, you're not going to send them into respiratory depression, especially with weight-based dosing, like it's safe. And so truly, if someone is in severe pain, just give them morphine or give them hydromorph. And then this is just a really nice Venn diagram for all the different types of pain, all the different like adjuvant things we can try. Generally speaking, again, our opioids are our mainstay for all pain types. Try to utilize non-pharmacologic approaches, like, you know, avoiding triggers for pain, movement, etc. If there are specific things, distraction, etc. And then treat underlying pathology. So if the cause is a huge mass in someone's femur, then consider radiation or palliative radiation. For inflammatory causes of pain, think NSAIDs and corticosteroids. For neuropathic pain, you can think anticonvulsants, TCAs, NMDA receptor antagonists, lidocaine infusions. For nociceptive, visceral, and somatic pain, you can consider interventional techniques, which we like don't do a lot of here, but that's thinking of like nerve blocks, and like epidural, things like that, regional analgesia and bisphosphonate. And then lastly, again, thinking about like our overall whole body symptoms, dermatologic manifestations, and MSK. So bed sores and pressure sores, super common. Ensure appropriate repositioning and mattresses. Edema can be managed with decompressive massage, positioning, decompressive therapy. There's actually like very specific guidelines that the occupational therapists follow for edema. So like there's very specific pressures and timing of how long Band-Aids can be on. So always consult with your like OTs and also wound care, super important. I also always warn parents that skin changes are very common. So some kiddos become mottled, pale, cool, and at other times kids might become really flushed and red towards end of life. And then just to say, like for a variety of reasons, like individuals can have a change in the way that they smell. Their skin breakdown, sweat, malodorous wounds. Like sometimes kids will have tumors that will get so big it like breaks open the skin on top and is really like malodorous. So for a variety of reasons, like the way that someone smells, like very commonly changes at end of life. And so it's not something that I commonly talk about with families, but just something for you to be aware of. Like I'm sure we've all had our different experiences. Some people may have seen someone dying, some people may have not. And so just to practically warn you from the perspective of walking into the room with someone who is dying, that the smell may be different. For really malodorous smells, like it sounds silly, but like there are lots of ways that you can mask the smell in the room. So like kitty litter under a bed, coffee grounds, like vanilla extract in a bowl of water. So like there are lots of things that you can do. And then for some of those like huge fungating wounds, we can put topical like antibiotic powder. You're not going to be tested on any of that, but just like helpful things to know and be aware of, because all of our experiences are different. And like some of these things are things that I wish that I had known when I had my first patient who was dying. That was it for the symptom management piece. In terms of defining end of life and impending death, things that you're looking for are profound progressive weakness, sleeping a lot of the time, little interest in food and drink, difficulty swallowing, decrease or like anuria, dropping blood pressure, changes in respiratory rate and pattern that we've talked about, those noisy breathing and airway secretions, changes in the skin, and those mental status changes. All like somewhat vague and blurry because people can have all of these and live for like weeks. So it's helpful to give a bit of an idea, but you always have to be aware that everyone's trajectory is different, and it is so hard to predict how long someone will live for. So when I talk to a parent, in terms of anticipatory guidance, I will always say, when someone is dying, we see like a variety of signs. Is it okay if I talk you through some of the things that we expect to see? And then really being calm, quiet, and like confident in the things that you're saying. So I will say, oftentimes people will become more sleepy or confused. This is really normal, and we usually don't treat with medications unless they're really distressed. Sometimes people will have hallucinations and they're actually really comfortable. And if they're comfortable, we won't change anything. We often see changes in breathing. Sometimes people breathe faster. Sometimes people breathe more slowly. Sometimes they'll have pauses in their breathing. Often those pauses become longer and longer until there's not another breath. Okay. Sometimes breathing can be noisy. What that tells me is that the muscles in their head and neck are really relaxed, and I like to liken it to snoring. It bothers everyone in the room but the person snoring. When people breathe like this, it's often not bothersome to them. And signs that we look for to see if it's bothering is to see if their face is relaxed, if they're grimacing, their eyebrows are not, or they're frowning. And then often their skin can be quite pale or cool. Everyone's trajectory is unique. At end of life, some people get really cool and pale. Sometimes people get really warm and flushed. And then the when will they die aspect of it all. Again, so infamously bad at predicting. The best we can do is often watch for progression of changes. It's really not fair to families to say you have 6 months left to live, because really with almost no exception, we'll be able to tell someone you have 6 months to live, you have 3 days to live. Our crystal balls are not that good, not that accurate. So the best we can do is watch for how quickly things are changing. So if someone is changing every few weeks, I'd say you might expect that you have weeks left. When you're starting to see changes or decline every few days, you could say, I expect that they may have days to very short weeks left. When you see changes every day, you can expect hours to short days. And when you see changes every hour, likely short hours. And so truly, it is not an exact science, but an estimate. And again, decline is not always linear. You will absolutely have patients who change every few hours and seem like they're at end of life, and then suddenly stabilize and are around for several more months. And so it's important that when you're giving this anticipatory guidance to families, that you're also acknowledging that we're really bad at predicting when someone is going to die. This is what, I tell families, this is what I look for, and that I will always be honest with you if I see a change or something that tells me otherwise. Sorry, it's a little bit cut off. This is not testable material, just helpful to know about. On the adult side, there's something called the Palliative Performance Scale, which is this big scale that kind of looks at ambulation, activity level, self-care intake, level of consciousness, etc., to describe someone's performance and function. And it helps us understand how sick someone is. So if someone told me they were PPS 100, they have full ambulation, there's really no disease, self-care is no concerns. But if someone tells me I have a patient who's PPS of 20, I know that patient is likely close to end of life. There's nothing like this on the pediatric side, unfortunately. This is a modified version. But on the adult side, they have estimated median survival in days, which is really helpful. And so it's nice to know about just from the context of if you ever hear someone talking about PPS, because sometimes people will mention PPS in pediatric patients, but it's for adults and really only validated in adults. And it's just a helpful piece of terminology, but absolutely not testable. So what do you do when someone dies? Please take your time. Once someone has died, they're most of the time, absolutely no rush. There are no legislations or regulations surrounding what you have to do to pronounce death. Good practice is to auscultate the chest for heart and lung sounds for at least 1 minute. I usually do 2. And when I auscultate, I usually tell families that I need to listen to your son or daughter's chest to confirm that there's no breathing sounds or heart sounds. It's gonna feel like a really long time. It's gonna feel like forever, but I need to listen for at least 2 minutes or 1 minute or whatever you like to do. Once I get to the end of 2 minutes, then I always say, I'm sorry, your child has died. I always use very clear language. It's you would think that it's very obvious, but you need to be very clear in these situations. Don't just nod, don't leave the room, be very explicit about what you've heard. This is from CHIO policies. I did my fellowship training here. I did my residency training in Halifax. So the actual algorithm itself, this flowchart, you don't need to know. It's just a framework that I'm going to use to show you or run through the things that you would do after someone dies. So zooming in, patient has died, MD is notified, you've pronounced, you're speaking with the family, seeing if they have any questions about what's happened. And then it's also important to determine if there are any religious or spiritual beliefs. Ideally, you've done this before the patient dies. So you can complete any rituals that must be done while the patient's still alive. Examples of different beliefs are having a sheet covering the body or the face of the child, having a body turned in a certain direction in the room, burial before sunset, having special clothes. But it's so important to have these conversations early because you want to have as much time as possible to know if a child needs to be buried before sunset, because if you find out at 3 p.m., it's going to be a rush. And then consultation with spiritual care early with the permission of family. Is it a coroner's case? So coroners, or in other provinces, we'll sometimes call them medical examiners. These are medical professionals that determine if there need to be like additional interventions or rather investigations after someone has died. So there's mandatory reporting to coroners in the context of like reportable deaths include deaths that occur suddenly or unexpectedly, deaths while residing in a long-term care home, deaths that appear to be the result of an accident, suicide, or homicide, deaths while in the care of CAS, or disease or sickness for which the patient was not treated by a legally qualified medical practitioner. So examples of coroner cases would be, like non-accidental trauma, or someone who like accidentally fell down the stairs, someone who like choked eating food. Those would all be coroner cases. There's a toll-free number. You can easily Google the number. You can ask Switchboard to connect you. You will be connected to a dispatch center where they take all the information. Then they're going to talk to the coroner. Then the coroner will call you and ultimately decide if the coroner, like they themselves, need to come see the body before transport. Don't remove any tubes, lines, etc. until after you get permission from the coroner. And then if the coroner decides that they have to come, they will be the ones to fill out the death certificate. Again, not like these are not just full things. These are just practical tips for in the hospital. If you are unsure if it's a coroner case, call. They will, like the dispatch center will talk to the coroner and determine if it's a coroner case or not. And then always call early because you never know how busy their call shifts are. They might be like all the way in, West Ottawa, doing a death certificate for another individual. So like the last thing you want is to wait until the last minute to call the coroner, and then you find out you have to wait 2 to 3 more hours before they can come, and then the funeral home can come. So like truly, if you are wondering if it's a coroner case, just call early. Yeah. Yep.
So let's say there were religious beliefs or something, and there's a timeline. Is that, I guess there's only so much the coroner can do with but what happens if it's like not going to be respected?
So when I call the dispatch center, if there is a religious belief or consideration, I will tell them immediately over the phone. If it is something like the patient is deteriorating at 3 p.m. and I'm worried because the family wants to get them to the mosque, they have not died yet. Usually we don't call the coroner before someone has died. But if that were the case and time were really tight, I would call the coroner's office ahead of time and say, like, look, I just need to know, can you review this with the coroner on call if this is going to be a coroner's case? And then unfortunately, like it will be a discussion with the coroner. Usually they're pretty reasonable and can act accordingly. Like they have a list of calls, but if you tell them that there is a religious reason why this patient needs to like get to the mosque as soon as possible, they can often say, okay, well, I'll come there first and then I'll go see my other patient. But always like a discussion with the coroner. It's usually like it's an MD. And so if you explain to them the situation, they're usually like very reasonable.
And is it like against the law for the family to bring the body elsewhere?
You're not supposed to move it. Like it would be very odd for the family to like try to move the body on their own. You could negotiate with the coroner, could the coroner meet them elsewhere? It will, I can't give you an exact answer. It will be a discussion with the coroner on call. Yeah, messy and complicated. Autopsies. So important to explore how the family feels about autopsies. If it is a coroner's case, usually the coroner will determine if an autopsy is necessary. If there are religious concerns or spiritual beliefs about not wanting an autopsy, you can usually tell the coroner and they will either say, totally understandable, we won't do an autopsy, or they might offer non-invasive autopsies. Autopsies are not what we see in TV. Absolutely, there are autopsies where they do the large central incision, but you can also perform an autopsy by doing like biochemical testing, imaging, non-invasive tissue sampling. So it's not black and white. Again, always a discussion with the coroner. If we know what the cause of death is, autopsy is unlikely to provide additional information. And even if it's not a coroner's case, the family can still request a hospital autopsy. If that's the case, you call the pathologist on call and navigate that together. Usually, though, if you know what the cause of death is, the family doesn't, like, I've never seen a family ask for an autopsy in the case of like a known genetic condition where we know that's the reason for death. Even if we don't know what the cause of death is, autopsy only provides additional information 30 to 50% of the time.
Can pathology decline?
I mean, in theory, they could. I don't think they do on the pediatric side. On the adult side, it's much more contentious because autopsies are really resource intensive. And so on the adult side, they absolutely can decline to do a hospital autopsy, but then families can reach out and find someone to do a private autopsy. Yeah, expensive. I've never seen it here, but it's more common on the adult side. So organ and tissue donation, again, I'm hoping that you folks will have further discussions with our critical care colleagues, but organ and tissue donation, there is a policy on ChioNet. I've just like copy and pasted some of it. But there is mandatory notification or reporting to Trillium Gift of Life. Here are some of the triggers for mandatory reporting in ventilated patients and also non-ventilated patients outside critical care units. Again, mandatory reporting, won't go into details. Do you folks, does anyone know if you have a session with, yeah, okay, perfect, I love that. Okay, and so not all families will be interested in hearing more information, but some families will want to know that organ and tissue donation were explored, even if it's highly unlikely that they are able to donate. So I will never say someone is not able to donate their organs or tissues until you talk to Trillium Gift of Life Network. And then it's just also like potentially a part of legacy creation, grief, and navigating death, whether organ and tissue donation are pursued or not. Sometimes families will come back after the fact and wonder if they could have donated. And so important to reach out to Trillium. What happens after someone dies in EPIC? So you go to the discharge tab and go to discharge as deceased. This is what it looks like, and essentially it's pretty straightforward. You go through and you fill out each of the sections. So deceased info, who pronounced, date that the patient death occurred, time it occurred, like so when you pronounced, where did the death occur, so on and so forth. Is there going to be an autopsy? All these things. Once you fill it out, click close. There's organ donation info and coroner's case. So was Trillium Gift of Life Network notified? And is this a coroner's case? And then orders needing cosign. There's nothing here right now, but essentially you can discontinue everything because they're deceased and aren't needing their medications anymore. And then a discharge summary. My only tip / suggestion for discharge summaries are to include time of death, pronounced by, whether Trillium Gift of Life Network was notified, coroner case or not, like all of those things from the previous fields we filled in, and then route that to their care providers, like family doctor, other subspecialists who were following. You can absolutely send them the entire 30-page PICU discharge summary as well, but I find that this is just a nice, short, like succinct summary, like in a few lines of what happened.
Do you have an easy family something or
Yeah, it's really challenging, particularly in cases where there is suspicion of like non-accidental trauma. So I will just say, like, as per like policy, because of the way that Johnny died, we have to consult another doctor who's an expert in this area to determine if there are other tests that need to be done before Johnny can go to the funeral home. And that's usually how I would describe it. If they have, like, usually parents have questions about the coroner because it impacts timing of things. And and I've never had any pushback. Is there like a certain situation you think of?
No, I just
Yeah.
don't know that.
Yeah. Yeah, I've never gotten any pushback, and usually like the times when I bring it up are like patients who like have like choked and died. And so like unfortunately, just like a part of our policy is something that we have to do. This is a medical certificate of death. Really like not too much to say. Read the instructions carefully, write legibly. And this is not the certificate of death that families get. So like, do not photocopy this. Do not give it to the family. The family will get a medical, like a certificate of death from the funeral. Often families will ask for a certificate for like insurance purposes, things like that. And that will come from the funeral home. The only thing to say is for cause of death, under immediate cause of death, I would generally say, for the sake of like Statistics Canada and our coroners, not to put cardiac arrest, because cardiac arrest is generally like a cause of death. Like that is death. The cessation of heart function is death. So like what caused that? Was it pneumonia? Was it an arrhythmia? Was it COPD or sepsis? So try to be clear, or as clear as possible if you know. And so it starts with the immediate cause of death and then goes down by like antecedent causes. So like pneumonia caused by functional decline, caused by like Duchenne muscular dystrophy. And then in the side, you would put approximate interval between onset and death. If you're like totally unsure, you can put underlying etiology unclear. Sometimes we get requests from parents, families, or questions about hastening death. We never provide or we never give interventions with the primary intent of hastening death. The foregoing or withdrawal of certain interventions may result in higher mortality, but that is generally with the intent of improving comfort or decreasing suffering. Parental requests for hastened death is often due to unmanaged symptoms, grief, fear, and really deserve further exploration. Has anyone had any requests for like MAID or hastened death or like questions surrounding that? Okay. It's not common, but it does happen occasionally. And I will talk about MAID next, but there's the doctrine of double effect, which lots of words essentially protecting an individual or saying that something is ethically permissible if the intention of giving a treatment is the positive outcome. It is ethically permissible even if there is a negative outcome, as long as the intention was the positive one. So for example, like really high doses of opioids, it is ethically permissible to give a high dose of opioid, acknowledging it might cause sedation and other ill effects, if the intention is to provide comfort from pain. That does not mean that it's ethically permissible to like start giving out like 10 times the normal dose of opioid. Like it needs to be within reason. But it's just the doctrine of double effect is simply stating that giving an intervention is ethically permissible, even if there is a negative outcome, if the benefit of like the positive intent is there. So medical assistance in dying is the provision of medication by a healthcare provider to hasten or cause someone's death. There's lots of very specific legislation requirements. Not everyone can request MAID. The biggest one that immediately excludes 99% of your patient population is that you must be 18 to be eligible for government-funded health. Must be 18 and must have a grievous or irremediable condition, be eligible for government-funded health insurance in Canada, and must make a voluntary request. So if anyone asks you about MAID, you can tell them that it's not legal in Canada for pediatric patients or those under the age of 18. There are some countries that offer MAID for pediatric patients. I think I've seen as young as like 8 or 9 in like European countries. There was a CPS statement that has also magically disappeared, page 404, not found. Which is unfortunate, but all you need to know is that it's not legal right now. And then palliative sedation, which we kind of briefly alluded to earlier, is different than MAID. It's the administration of proportional sedation for the treatment of refractory symptoms. They're typically administered in individuals with refractory symptoms who have a reasonably foreseeable death. So refractory seizures, you give palliative sedation, and you wouldn't just start with your highest dose. You would start low and up titrate until the seizures stop or until the patient gets relief from whatever their refractory symptom is. This could be dyspnea, this could be pain, it could be anything, but it's for refractory symptom management is always like the last step. It doesn't have the same legislation that MAID has, and there's no rules for age or anything like that. And studies show that it does not hasten death. You might say, that's really weird. You're sometimes sedating people to the point of not being able to eat or communicate. How does it not hasten death? That is in the context of reasonably foreseeable death. We're not providing palliative sedation for the most part in individuals who have, like, for example, Huntington's disease and might have a very long lifespan. There's a lot of really interesting ethical dilemmas and explorations of whether or not it's permissible. We won't get into it today. There's really no legislation right now, but just know that it's for refractory symptoms at end of life in patients with a reasonably foreseeable death. When we talk about death, it's important to talk about bereavement and grief. Grief is not linear. There are many different theories of grief and many different types of grief. It's going to look at different developmental stages. So at the very end of this, I've included some like developmental stages for how children at different ages understand grief and death. Not testable. They're never going to put that on your Royal College, but just helpful to know when you're going into a room and talking to a patient, even about goals of care. Because grief is not just after the loss of something, it can also be anticipatory. So a response to anticipated loss. Grief is the normal response to loss, and then bereavement is the grief specific to the loss of an individual to death. I've linked kidsgrief.ca, which is a fantastic resource for parents, for children, for healthcare providers, just in terms of like, if you're a child, understanding what grief is. If you're a parent, how to support your child, how to support yourself. There's resources for health providers as well. It's really good. So would recommend taking a peek. Yeah, I know. I think we have time. I think that Andrew Garfield does an amazing job of explaining grief. If the volume works, we'll listen. Anyway, So what we can learn from Andrew Garfield and Elmo is that we're going to create space, even though it can be scary or difficult to ask about how people are doing. We're going to listen. And also grief is complicated, it's messy. Grief means that we can celebrate that the people we love, like celebrate the people we love and miss, but that we can also miss them. This video popped up before I could talk about the different theories of grief. You're not pediatric palliative care fellows. You don't need to know about the 5 stages of grief. You don't need to know about the dual process theory of grief. Just know that grief is complicated. It's messy. And a lot of what grief is navigating your relationship with your environment and the person who you've lost and the people in your life. Yeah. Oh, no, we don't need that. All right, moving on. Cases, and by cases, it's like one really long case, and I promise it's not that long. So you have a 14-year-old male, James, with metastatic Ewing sarcoma. His primary site was in his femur, but he has significant mets to the lungs, spine, and pelvis. He's still receiving chemotherapy, but they have been told there are no further curative options. He's receiving chemotherapy to prolong his life, but understands that he will ultimately die from cancer. He is not for intubation and not for his CPR. He is not taking any other medications right now outside of his chemotherapy. What are some symptoms you might expect with progression of his cancer? Pain, yeah. 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 Mets to the lungs, absolutely.
Difficulty to move.
Yeah. Yeah. So let's start with let's talk about dyspnea. So James is seen in clinic and is found to have SATs in the mid-80s. He's slightly tachypnic and has some increased work of breathing. He's unable to speak in full sentences, but appears otherwise calm. When you ask if he's feeling short of breath, he denies this. His parents become quite worried and ask about oxygen. Thoughts? What are you thinking? I'm seeing some like shaking heads. Is that like unsure or? Yeah, exactly. So you can provide reassurance to the family. We're not looking at numbers. Oxygen would not necessarily be helpful. When James returns a few weeks later, he continues to have moderate work of breathing. However, now he tells you he's starting to feel short of breath, especially with any ambulation and mobilization. What are some suggestions for his dyspnea? What is like a non-pharmacologic thing you could do? Yeah, exactly. Fan for the face. It sounds like he's still ambulating, so you could even get like one of those little like handheld fans. What about pharmacologic interventions? What is like our mainstay of pharmacologic treatment for dyspnea? Oh, I heard someone say opioids. Yeah. So that's absolutely where we would start. 1/4 to 1/2 the starting dose for analgesia. It sounds like it's only with ambulation/mobilization. So you could try doing PRNs first. You could also do something like a Contin or long acting if it's something that bothers him more throughout the entire day. So his dyspnea is initially well controlled and continues to worsen. He eventually ends up on a hydromorphone and midazolam infusion with patient control boluses. He also finds comfort leaning forward and laying on his right side. I put this in as a reminder to when you have a patient who is dyspneic, to look at their imaging and figure out what is happening. Is there compression of a specific area of their lung? Oftentimes patients and our patients will find a position that's most comfortable to them. But often, for example, if all of the mets were in the left side of his lung, or primarily the left side, he might find more comfort sleeping on his side with the right side or the aerated portion of lung up high. He starts coughing up red sputum. What might this make you concerned for, and what would you do? We didn't talk about this during the lecture. Skill testing question. Yeah. I'd be worried about blood. Does anyone know what we might do for someone who is having blood in their sputum at end of life? So if like the biggest indicator that someone is going to have a terminal event where they have catastrophic bleeding is the presence of blood in their sputum. You can absolutely have someone have a catastrophic bleed with no indicators beforehand, but commonly they'll start to have blood in their sputum. And like there's really not much we can do. So we have dark colored blankets, towels. It's really distressing to see blood on white bed sheets. So we make sure that we have dark bed sheets. Anticipatory guidance for families that this is something that could happen, but if it happens, we will give them a medication to keep them really comfortable. So we essentially give a huge dose of benzodiazepine to like essentially palliatively sedate them and provide comfort, because that level of catastrophic bleeding will eventually result in death. If it's small amounts of blood, always important to see where it's coming from. Is it actually their lungs, or are they having nosebleeds that just going posteriorly? If it's nosebleeds, you can pack with like epinephrine soaked gauze or TXA, put like pressure over the nose. But this is more common in our oncology population. So, skill testing question. Not where I want to go next. Okay, so we've talked about dyspnea. Someone also. Oh yeah.
What would that be compared to?
It depends on the like size of the child, but like starting with 10 milligrams, and then like if they're still awake and distressed, you just keep adding more and more. Yeah. So what are symptoms that you might expect? Sorry, so someone said pain. James has been largely asymptomatic, but is starting to have some pain in his left femur, the primary site of his tumor. What kind of questions would you ask him about his pain?
Can you have the pain all the time overnight as well, for example?
Absolutely. So the pain is 8 out of 10. It's worse whenever he moves his leg. He's tried Tylenol with no effect. It feels like throbbing, but also like stabbing. It feels deep and in the bone. On imaging, there are no obvious pathologic fractures, but there is significant disease spread throughout his femur and now also going into like the soft tissues of his muscles. What kind of management would you consider for this kiddo? Yeah, 8 out of 10 pain, opioids. Tylenol, like also we know Tylenol is not helping, but if someone told me they had 8 out of 10 pain, they have a gigantic mass and they're like, absolutely, start with opioids. You can always like add in other adjuncts. But for this kiddo, he started on short-acting hydromorphone and is eventually transitioned to hydromorphcontin with short-acting PRNs with good effect. James has been largely managed at home for the last several weeks. His consciousness is significantly reduced and he's no longer ambulating. He's about an hour and a half away from the city. During repositioning, his mother hears a snap from his leg and James starts crying in pain. He's on a baseline hydromorphone infusion and midazolam infusion for his dyspnea. What are some considerations for investigation / management? This one is tricky, and it's kind of a rude question of me to ask.
Imagine to see if there is any positioning or intervention that you could do with the leg to reduce the pain. For sure, you need escalating pain management for sure.
Absolutely.
But he lives 1 hour and a half away. Is he at the hospital now?
No, he's still at home. You got a call from mom at home, which I know you guys don't get calls from parents at home, but for the context of this case, this is all to say that like
could increase the pain medication if he feels comfortable. With
exactly.
The caveat that if he's not feeling comfortable, then maybe further investigation just to adjust the position would be helpful.
Yeah. So it's all about the goals of the patient, right? Like, and what what different interventions would offer and what investigations would offer. So like, could we image his leg? Absolutely. If that was the family wants, maybe. But knowing that they're an hour and a half away and that he's in a lot of pain and he's at like the end of his life, he would not be a candidate for surgery or like surgery would not be something that we would recommend for this patient. So moving James at all is extremely distressing despite increasing his hydromorphone infusion. When he is not being moved, his pain settles. Outside of becoming confused and agitated with movement, James largely is non-communicative, less responsive, and has significantly declined in the last few days. The decision is made to increase pain management at home instead of further investigation, as it is felt that the transport to the closest emerge for imaging will cause more pain and suffering, and that they would not pursue any invasive interventions. James died peacefully 2 days later. But again, it's always going to be dependent on your patient and exploring what their goals are and what is suffering to them. Like some families might say, like, I need to know what's going on. In which case, like, you do your best to accommodate and adjust it accordingly. Maybe they really want imaging. Can they get imaging somewhere closer to home? And can we like up his pain meds, make sure his pain is well controlled? Is there anything that you're worried about knowing that he has metastasis to his spine? Yeah, vertebral fractures. This is another read question. It's not one that we covered during the lecture. Good job. I'm really proud. Yes, exactly. It's considered a palliative care emergency. I didn't cover it because again, it's not something that is likely to show up in your exam. It's just something that's good to be aware of when you have a patient who is end of life, when you're thinking about what are all of the symptoms that he could get or they could get. If they have spinal meds, worry about spinal cord compression. So James begins to have significant lower back pain that radiates down his legs. He doesn't tell anyone because he's worried about what it means. Today he wakes up and is unable to move his legs. He's experiencing some urinary retention. Everyone said worried about spinal cord compression. James is sent to the emergency department for an urgent MRI of his spine. He's found to have spinal cord compression at T6 to T7. Does anyone know what next steps are for spinal cord compression? Yes. Oh my gosh, folks are superb. Steroids and then urgent neurosurgical and ortho consult. So James is immediately started on dexamethasone. Neurosurgery / ortho is immediately consulted for tooth debunking. He goes for surgery, which is successful. He's able to return home with return of ambulation after several weeks. Time is, I was going to say spine, not really spine, but like the earlier you diagnose it and manage spinal cord compression, the more likely you are to successfully regain ambulation and prevent long-standing damage. We've actually had quite a few spinal cord compressions over the last 2 years. And then I think I only have one other thing. Okay, nausea and vomiting. James starts to feel significant nausea. What are some potential causes for James' nausea, and what would you ask him? Yeah, he's on chemo. Could it be the chemo that's causing his nausea? Constipation, amazing. Yeah, could it be constipation? Could it be opioids? Oh, amazing. James' nausea specifically started after starting morphine for his dyspnea. On further questioning, James has never had morphine before. Wait. If you found out that it started right after his dyspnea, right after starting morphine for his dyspnea, what might you consider doing with his opioid? Yes! Let's pretend that I didn't just immediately give you the answer. Hold on. Okay. On further questioning, James has never had morphine before and becomes very nauseous after each dose of morphine. He also has pruritus, and so the decision is made to switch to hydromorphone. Despite this, he continues to have significant nausea. On further questioning, you find out that he's not had a bowel movement in 4 days. What recommendation would you make, and what can you do in the meantime for his nausea? Absolutely, if he'll start, if he can tolerate oral medications, absolutely PEG. Does anyone remember those other medications that we talked about that I didn't put in the slide? Mora. Yeah. Naloxone, methyl naltrexone, like For him, I would honestly start with PEG and other things first, but you could always go to methyl naltrexone or naloxone. There's so many other things that we could talk about regarding potential symptoms, but you folks have been so patient, so I'm going to go to resources. These are all links. So in the slides that you have, if you click, it'll bring you to the appropriate slide. So these are the developmental stages in grief I was talking about, their understanding of grief and expressions of grief. And then CPS, goals of care, advanced care planning. The Canadian Pediatric Palliative Care Alliance recently released their new updated website. I would highly encourage you to go check it out. They have a resource hub for healthcare professionals with training modules and toolkits to help healthcare providers. Kids grief we talked about, and then the pediatric palliative care approach to pain and symptom management is the little handbook of all of the different medications and doses that we often use. And so I've included a link to that here as well. I didn't include them in my lecture because you can easily find them, and I have the link to it here. Also, depending on where you look, everyone's going to have a little bit of a different starting dose. So you're absolutely never going to get tested on your exam for the starting dose of any of these end of life medications. And that's it. Thank you. Does anyone have any questions? I know that was a lot.
Very helpful. Thank you.
Was there anything that you folks are like, man, we've covered this already, next year, take it out, or in the following years? The review was short enough at the beginning?
Yeah.
Okay. Again, super heavy content. If you have questions or want to talk, you can my email was on the very first slide. Or I'll hang out for a few minutes after. But thank you for going through all of this with me. That's unrelated to this. Okay. Yeah, thank you folks so much, and please enjoy your lunch break. Take it easy today because it's very steamy. But also appreciating you have more lectures this afternoon. So good luck. Good job.
Thank you.
Maybe not in a giant ego. I'm gonna do med student and have a lot of time, and then if you were not. I would be. And honestly, bowel issue. I'm med here. That's basically they were kids. Million. Yeah. And they were like, yeah, we've been here. And we've done it. But then they got right there. But yeah, I think it starts here. Maybe with 5 times. I know. So and they looked at her and we've been to Chicago. Thank you.